in a large population sample. There have been very few studies before the 1970s and the 80s to look at the prospective data, but now we have a lot of information, and we have understanding of a natural history, which is a key issue if we want to prevent diabetes. We know that pre-diabetes is common. When we looked at the European population, we could see that in the elderly population, about 25–30% have a pre-diabetes. So this is a stage where we can actually act to do something, because we know that from pre-diabetes, impaired glucose tolerance, in 10 years' time, if nothing is done, half of the people will have diabetes. And from the UK PDS study about 20 years ago, when they recruited individuals for a trial, they realized that at the time of the first diagnosis of diabetes, there was about 50% loss of the beta cell function, and it was decreasing over time. And extrapolation backwards showed that maybe approximately 12 years before the whole process had started. So there is a window of opportunity which can be used if we just identify these people before the clinical diagnosis of diabetes. Now then comes the issue, what is important for us? What shall we do? And today we call for evidence-based medicine. We should not do something where we don't have any evidence that it works. But there are many different ways to obtain the evidence, and most important way is randomized controlled trials. But there are also things that do not require or the randomized controlled trials cannot be done. So the observational studies are also very important to understand what is actually happening in the population. But the proof of the concept for prevention comes from randomized controlled trials. One of them was our Finnish diabetes prevention study, which was the first proper randomized controlled trial in diabetes prevention, where we had intervention group and a control group. A very simple intervention. We only took 5 goals: diet, physical activity, weight reduction. It was very simple intervention in a way. We did not try to modify all possible risk factors that were known. We wanted to have the most important ones. And then the outcome was very successful. We could demonstrate a 58% risk reduction in the incidence of diabetes in the intervention group compared with the control group. Very clear that the prevention works. And you can see also from the slide that the prevention worked immediately. After 1 or 2 years, the curves started to separate. So you don't have to wait for decades to prevent diabetes in the high-risk individuals. The benefits are there immediately. Now there have been then several other studies, and surprisingly the US DBP, 1 year later our publication, they came up with exactly the same 58%. And in the Netherlands, again, 58%. In the UK, 56%. Also here in India, in Ramachandran's trial, showed very nicely about 30% reduction. And the absolute risk reduction was identical with ours. The relative risk reduction was smaller because the incidence was much higher in both groups. So it's a kind of a statistical trick to talk about the relative risk reduction and the absolute risk reduction. So clearly here the lifestyle intervention worked, but also metformin therapy seemed to be working. What was interesting to see that the combination of metformin and lifestyle intervention did not have any additive effect. So basically one has to choose what to do, but lifestyle intervention in the US trial was much more efficient than the metformin therapy. Here in India, Rajchandran also carried out the SMS-based intervention by telephone, and very nicely demonstrated a 36% risk reduction with a very simple SMS messages, which is a kind of example how modern technology can be used and actually save a lot of time and energy from both healthcare workers and participants. And summarizing the different studies in the Asian populations in China, Japan, India, about 45% risk reduction has been seen in the meta-analysis of these trials. So prevention works, definitely. Now, these trials were based on the people with impaired glucose tolerance. But then there is another way of identifying diabetes which has been promoted during the last 10 years, especially using A1C. But using the A1C and trying to identify prediabetes actually brings in very different individuals compared with the IGT or impaired fasting glucose. So then we are talking about a different type of individuals. And this is a question then, we have no data, we have no evidence that the prevention will work in the pre-diabetic individuals based on a hemoglobin A1C. We don't know. And we also have a very little information about the fasting glucose, using the impaired fasting glucose as a pre-diabetes criterion. And the only one big study that has been carried out in the people with impaired fasting glucose was published 7 years ago from Japan, and they looked at the intervention which resulted in 44% risk reduction compared with the control group. It looked like the people with impaired fasting glucose will benefit also from lifestyle intervention, but when they separated people who had both impaired fasting glucose and impaired glucose tolerance, there was 59% risk reduction, whereas in the people who had isolated IFG and a normal 2-hour glucose, there was no benefit from lifestyle intervention. So still we don't know why it happens, but we understand that the pathophysiology of the fasting glucose is very different from the glucose tolerance. So after meal, the increase in glucose, of course, is different than what happens in the morning after overnight fasting. There is a very different mechanism of increase in the glucose in that sense. What about if you use the A1C as the outcome in the diabetes prevention studies? We looked at it in our study, and you see that if we would use the 6.5% criterion for hemoglobin A1C being diabetic, the results from our trial would have been nil. There was no difference between the groups if we would have used only hemoglobin A1C as the outcome variable. But using a glucose tolerance test, we could identify 58% risk reduction. And this has been also demonstrated in the other studies like in this one in Barcelona. They looked at the people who had a high diabetes risk and who developed diabetes. About 200 people developed diabetes based on the glucose tolerance test, but only 31 with the hemoglobin A1C. So A1C is a very, very insensitive in the early diagnosis of diabetes. Now, how long will it take to help individuals with the lifestyle intervention? In our study, which lasted 4 years, we followed individuals 15 years, and we could see that there was a continuous long-term benefit, and the diagnosis of diabetes in the lifestyle intervention group was delayed or postponed by about 5 years. So lifestyle intervention brings in lifelong benefits for the individuals who are taking part. Now recently also this Ramachandran's SMS trial follow-up has been published, and again it seems that the follow-up without any further intervention showed that people who received SMS messages, they had a lower risk of diabetes in the long term for 5 years. So it's a good news. The diabetes prevention, although it is a lifelong issue, but from the healthcare or the provider point of view, we only have to do a short period of time the intervention, and then the benefits are there. So several other studies have looked at the situation, and in the meta-analysis you can see here that the pooled estimate is about 30% risk reduction in the long-term follow-up after the intervention. Whereas if you use medication and stop medication, the people will in a few weeks' time already return back to the situation where diabetes risk is similar in the treated than in a control group. Now a few words about the precision medicine, the personalized medicine, because I would argue that type 2 diabetes is a very good example for precision medicine. We know the genes, many genes, we know the risk factors, biomarkers, and we can predict, we can identify high-risk individuals with a very simple tools like this one, which has been developed by us in Finland, where we are having people assessed based on a very simple non-laboratory variables and then calculating the overall score. So we developed it in the 10-year follow-up of the population cohort, and you can see that those individuals who had a high score value, most of them developed diabetes in 10 years, whereas a low score means that hardly anybody develops diabetes. So we can identify those people who have a high risk. And this has been now used in 20 languages all over the world in different populations. But there are also other scoring systems developed, for instance, in Thailand and also in India. Actually, there are 2 or 3 different alternative scores in India. And these are very simple things to do, and we really have to use them in the public health because it's inexpensive and it can be used in a very simple way to identify high-risk individuals, testing a glucose, diagnosing undiagnosed diabetes, and then to have a preventive interventions as we have done. And we looked at the long-term cohort of about 10,000 individuals in Finland, and the score system works very nicely. That the high risk based on the scoring system really have a high risk. But also this can be used in the primary care to actually intensify the prevention programs like this one in Catalonia, where they found that identifying high-risk individuals with a risk score in primary care and then intensifying the lifestyle advice was almost 50% risk reduction over a 2-year period. So the one thing is, however, that 2-hour glucose tolerance test, which has been recommended, takes 2 hours, and many people don't want to wait 2 hours, and the laboratories are not willing also to do it. So there has been also a 1-hour test for glucose that has been promoted now, and it seems to be working very nicely. So to have a 1-hour 50-gram glucose load will identify diabetes very nicely, and also pre-diabetes with the different cut points. So I think this is something to be discussed. Of course, I would love to see that the continuous glucose monitoring is a way to diagnose diabetes. That is the best, but so far it is not possible yet at the population level. Genomics in precision medicine is something which is a basis, and we know, actually we just have published the latest paper, and now we have 400 different genomic loci that have been identified to be associated with the type 2 diabetes, but only a few of them really have been identified to be a causal so far, for diabetes. But about 20% of diabetes risk really comes from genetics, and about 80% from the lifestyle. Genetic risk score can be also developed, and it has been developed in different ways. You just take these loci and see how many risk alleles you have in your patients, and then you can have a score, and the more you have these loci, the higher the risk. And that could be a basis for the management of diabetes prevention. Now we have, in our Finnish diabetes prevention study, we have looked at the many different candidate genes identified recently, one of them here. And in the control group, we can see that those individuals who had a very high risk and were homozygous to 12 allele, in the intervention group, these people had the lowest risk. So high-risk individuals seem to be benefiting more, the genetically high-risk individuals seem to be benefiting more from lifestyle management than the others. So this is a good news. And we looked at also that which type of information was helpful. And for those who had 12 homozygous, they benefited from physical activity, but those who had 9 allele, they did not. There was nothing happening with the physical activity, but they benefited from a healthy diet. So we can tailor the intervention in that way in the future with a simple genotyping, which is becoming very, very inexpensive, and different methods have been developed to actually do the population-based genotyping for the risk in order to enhance the lifestyle intervention. But finally, nothing works if people do not adhere. No drug works, no lifestyle intervention works. We looked at the weight change at year 1 after the intervention, and only 1-year intervention already showed very clearly who will benefit from the lifestyle intervention in the long run. You can see it here that those who had the biggest weight loss in 1 year's time. They had the best outcome in the long run compared with those who did not change their body weight at all. But the most important thing is the combination of a lifestyle. Healthy lifestyle is not a single thing. It's a combination of many different items, and if you combine all these 5 simple lifestyle targets we had in our study, if people managed to reach these targets, nobody became diabetic. Adherence is a key issue. And you see also that those who did not achieve a single one of those, 35% of them develop diabetes. So this is important. We have many open questions still. What is the uptake of enrollment? Well, how to improve the health outcomes? What kind of biological intermediate parameters we should use? And what are the barriers and the problems in the adherence? So there are many things. We need a lot of research still to actually come with the recommendations. I would like to end my talk showing a slide from this country. It's the first paper published on diabetes prevention. It's already published 1895, and clearly describing that diabetes is a problem in India, and also mentioning there that there should be a preventive measures to be carried out to prevent type 2 diabetes. So it's a long story, and we are still struggling in the middle of that, but this is something where we have a fantastic success so far. Now we have to implement and translate our research findings to a real-life practice. Thank you very much.
Thank you very much for a very wonderful and thought-provoking lecture on prevention of diabetes. And as many of the studies have suggested, almost 56 to 58% reduction in diabetes, and in our own Indian study also has proved it, that lifestyle modifications does help. But actually focusing on it and actually making people do it is a problem. Identifying the IGT in the population is also a problem. So that's where I think where we as healthcare providers should work on it. Any questions from the floor? If there are no questions, we'll go on to the, 1 minute. Sir.
Felicitation of the speaker, please. Friends, our court trial cautioned us that going too low may be fraught with with cardiovascular complications. So the next talk is controversies on hypoglycemia and its association with CVD risk. And this talk will be taken by Dr. Simon Haller. He is the Professor Clinical Diabetes at University of Sheffield. He is Director of Research and Development. He is a member of UK NIHR Health Technology Assessment Panel, National Specialty Lead in Diabetes to the NIHR Clinical Research Network. Over to Dr. Simon Haller, sir.
Good afternoon, everybody, and thank you for that kind introduction. I'd like to start by thanking Dr. Banshee for doing me the honor of inviting me to participate in this meeting. So my first talk is about the ongoing controversy of the relationship between hypoglycemia and cardiovascular disease in diabetes. I have disclosures. And I'm going to first talk about the recent trials of intensive glucose lowering and their relationship to cardiovascular outcomes. And I'm going to advance the hypothesis that perhaps they didn't show the expected benefit because the intensive therapy was causing hypoglycemia. And I'm going to produce and show you data both for and against that hypothesis. I then want to show you studies that we've been undertaking, experimental and clinical studies, to explore this relationship, and then come to a conclusion. So this slide shows a Fourier plot from a meta-analysis published in The Lancet in 2009. And what it does is to show the effect on all-cause mortality. We could have done the same for other cardiovascular outcomes, according to comparing the standard and intensive treatment. And as you know, in newly diagnosed patients in UKPDS, there were big changes in microvascular disease benefits, and there was a strong trend at the end of the 10 years of the study towards benefit, particularly for myocardial infarction and indeed mortality, which didn't reach significance. And you'll also know that further follow-up demonstrated that that did reach statistical significance. So the hypothesis was that if we could really intensify control in patients at high risk, we would show benefit. And 3 trials were undertaken and published some years ago. So here's Advance. I was involved in Advance, and indeed I think Indian patients participated in that trial. Very large trial of in over 11,000 patients. And here you can see the relationship between this tight glycemic control and mortality. There was a trend, a modest trend to benefit, but the confidence interval crosses the line of unity, not significant. VADT actually showed a trend towards disbenefit of intensive treatment, big wide confidence intervals because of low numbers. But I think it was the premature termination of ACCORD because of clearly increase and a consistent increase in mortality, which led to the premature discontinuation of the study after 3 years, which startled the community. These were patients with established disease. You would have expected them to benefit, but they did not. And indeed, they did worse. So if we add all that up, you can see that there's really no benefit of tight control, according to this meta-analysis. And the question is why? What was it about ACCORD that caused that increase in mortality? Was it weight gain? Was it medication? Or could it be hypoglycemia? And some of us have thought that it might. So look at these rates of severe hypoglycemia in these trials, and you'll notice that as the rates of severe hypoglycemic go up, so the benefit becomes less. So I think that's an interesting observation. We mustn't overinterpret it. So even in Advance, there was a relationship between severe hypoglycemia and subsequent mortality. That was true for VADT as well. It was the strongest independent predictor of mortality. In ACCORD, severe hypoglycemia was associated with increased mortality, but to a greater extent in those in the standard group, and I'll come back to that. And even in Advance, with low rates of hypoglycemia, there was an increased mortality. But note, not at the time of the event, but downstream, indeed many months after the event. So we looked at the Advance data in more detail and published a paper in the New England Journal of Medicine. And what we did was to look at various outcomes, which are listed on this plot, as you can see. In those patients, only 230 out of the over 11,000 had an event. And we looked at the hazard ratios, so major macrovascular events, microvascular disease, death from any cause, and cardiovascular disease overall. High hazard ratios throughout. So you might say, well, that certainly suggests causality. But please note, if we looked at non-cardiovascular outcomes, respiratory, gastrointestinal, we also showed an increased hazard ratio. Now, we reasoned that they could not be due to hypoglycemia, and in our discussion, we made the point that could it be that severe hypoglycemia was a marker of vulnerability, comorbidity, frailty, if you like, which predicted people would die. In other words, were we looking at a risk marker with suggestion of causality, or were we looking at a risk beg your pardon, risk factor, which was causality, or risk marker, which would suggest vulnerability. And that debate has been going on and on for the last few years. But I point out this epidemiological study looking at, in observational studies, over 900,000 patients, where they found a strong association, and they worked out using statistical techniques that comorbidity alone could not account for this association, and they thought that the association was likely to be a risk factor. And that was their conclusion. And one of the reasons that they came to that conclusion is that there were very plausible mechanisms whereby hypoglycemia might increase cardiovascular disease. I'm going to show you data shortly about platelet activation and blood coagulation abnormalities. There's evidence that hypoglycemia can increase CRP and certain cytokines, increase inflammation, evidence for endothelial dysfunction, at least at the time of hypoglycemia. And of course, we know that when hypoglycemia occurs and epinephrine is generated, that's going to increase myocardial oxygen demand and may cause angina or even myocardial infarction. And there are effects on arrhythmias. So our group have been trying to investigate this for the last, well, nearly 10 years now. I just want to share with you some of the challenges if you are going to research in the area. So if you're going to do experimental studies, the obvious thing to do is to clamp people at hypoglycemia and make measurements. But for ethical reasons, you can't choose people who've got high cardiovascular risk. You can't push the glucose down probably below 45 milligrams per deciliter because it's unethical, of course. And most important of all, you've got to try and predict mortality downstream, not at the time of hypoglycemia. If you do clinical studies, which are now quite easy to do, as I'll demonstrate, cardiac events are rare, even in people with high risk. If you're going to put monitors on people for the next 6 weeks, even if they've got a high risk, they're not likely to have an event. And in type 2 diabetes, severe hypoglycemia is relatively uncommon, and we've only just been able to use CGM, as we've heard already this afternoon, in terms of its accuracy. So let me share with you some data. This was an abstract, although this has just been accepted for publication in Diabetes Care and will be appearing in the next few weeks. It was undertaken by a very gifted PhD student working in our group, Elaine Chow. And what she did was to take people with type 2 diabetes, brought them in, and on one occasion she clamped them at around 45 milligrams per deciliter, and another occasion she kept their glucose at normal levels, euglycemia. And you can see on this slide, when she made measurements of different aspects of blood clotting and circulating acute phase proteins, she found some interesting observations. And what she also did was to bring the patient back not only at the time of the clamp, but the following day and indeed a week later. So let's look at clot maximum absorbance in the top left-hand curve, and you can see that during hypoglycemia in the open triangles, there is indeed an increase. You'll also notice that during euglycemia, there's an improvement. Clot gets less, and that is because of the beneficial effects of the insulin, which we controlled for. You'll also notice that at the end of the clamp, which is shown in orange, there's no significant difference. It's only a week later that you really begin to see changes, so that will be consistent with the downstream observations. If we look at the time taken for blood to clot, you can see actually that was stimulated and a difference at the end of the clamp, with clot lysis times going on, blood taking longer to lyse, blood clot, and that was then consistent up to a week later, but it's beginning to diminish. I think acute phase proteins, particularly fibrinogen, is really interesting. If you just done the clamp and sent the patient away, you'd said, oh, it has no effect. But look, at a week later, there's really a marked increase in fibrinogen, and the same is seen for hsCRP. So could it be that repeated episodes of hypoglycemia are just upping the inflammation and reducing the benefit from tight control? and it's a hypothesis, of course. We've also been interested in arrhythmias and their case reports of all these arrhythmias occurring during hypoglycemia. We've been particularly interested in this, so we tested this hypothesis that during clinical episodes of hypoglycemia there's an increased risk of arrhythmia. We also measured autonomic function and cardiac repolarization. So Elaine took these 25 individuals with type 2 diabetes and she just sent them away with an ambulatory electrocardiogram and a navigator CGM. And the first thing I want to share with you is to show the difference between hypoglycemia during the day and the night. If you look at the scales, the day episodes are kind of classical hypoglycemia that we learn about actually in medical school or during our training. They last 80 minutes, the glucose goes down to around 55 and then it comes up again. Patients are often symptomatic. But during the night, those episodes were going on for an average of 3 hours and the glucose was lower. You can see the error bars are big. Some of these glucose values were very low indeed. And here's an example of a patient. So if you look at the top, we've got the QT interval, a measure of repolarization, and we've got the glucose underneath. And at the bottom, we've got the electrocardiogram. So if we look at the glucose, you can see that in this patient, glucose went down to 1, and it stayed there for 4 hours. This patient stayed asleep. And when they woke up in the morning, they didn't think anything was wrong. But if you look at the electrocardiogram, and the QRS has been truncated, that's the bit in red. Look to the right, that's the T interval, the repolarization. And you can see about an hour or two after the patient's become hypoglycemic, the T wave becomes very abnormal, it flattens out, the QT interval gets longer, and that is shown in the top graph. And you can see that the QT interval is going up, and it reaches 500 milliseconds at around 4 a.m. And that, in other conditions, in ischemic heart disease, is associated with sudden death. Now, none of these patients died. We also looked at arrhythmias, however, and although nobody died, they did have some abnormalities. You can see that in terms of ectopics, there was an increased incident rate ratio of 4-fold. In bradycardia, there was an 8-fold increase. And I should emphasize that not all the patients had it. This was confined to just a few, I think 5 out of the 25. But nevertheless, if we look at the electrocardiogram, this is one example. You can see out of glucose of around 45 milligrams per deciliter, the heart rate's going at 30 beats per minute. This is a patient with known ischemic heart disease, and they're having ectopics. You can't really imagine that this is a healthy thing. Elaine has also brought people into the lab to look at these, and here's a clamp study, which again we published last year in Diabetes. And you can see that she compared people with diabetes to non-diabetic individuals. They were clamped for 2 hours, and here's the heart rate during the clamp in both groups. You'll see that the diabetic group have a higher resting heart rate. That actually proves problematic to us when we measure QT intervals, because they're corrected for heart rate, and that makes it difficult to interpret. But nevertheless, if we look at hypoglycemia, you can see that the QT interval goes up to a greater extent in those with diabetes. Nevertheless, this doesn't reach statistical significance, and we were a bit suspicious that the increased resting heart rates may have accounted for these differences, which in fact weren't significant. So we measured something else called T-wave symmetry. That is actually the time taken for the T-wave to go to its maximum compared to the time taken for it to fall. And it's rate independent. That's its advantage. And the closer it is to 1, the greater the abnormality. And what I think is very interesting, that in the non-diabetic group, there's no effect. But if you look at the diabetic group, you can see that the T-wave has certainly changed. And could it be that they're more susceptible? And that was significant, 0.2. For those of you who remain skeptical about hypoglycemia causing death, I'm going to show you this slide from somebody with type 1 diabetes, because it shows a 23-year-old dying from hypoglycemia. This is a patient on a pump, the best way of delivering insulin, so we're told. And this was a patient who started the day at 250 milligrams per deciliter, their glucose fell during the day, and they did some exercise, shown in purple. The glucose shoots up to 250. He didn't really get the amount of carbohydrate right. And then he does what people on pumps should never do. He stacks his insulin. In fact, he gives 5 bolus doses of insulin over the space of 3 hours because his glucose hadn't come down. Then he goes to bed, his glucose plunges to hypoglycemic levels, and around 6 a.m. he dies. At autopsy, there's no evidence of any brain damage. He almost certainly died an arrhythmic death. So to summarize, I think that hypoglycemia is important in different ways. I think repeated episodes, as we now know, impair counter-regulatory responses, particularly catecholamines, and increase vulnerability to impaired cognition, crashing cars, and severe hypoglycemia. It may be that occasional episodes in poorly controlled patients which produce a lot of catecholamines may be particularly lethal, and that's a hypothesis based on ours and other data. And could it be the reason that it was the standard group in ACCORD who had the highest risk of death following hypoglycemia? And then finally, we've described, as I've shown, these prolonged asymptomatic episodes overnight with increased QT interval. Could they also be important and clinically relevant? So these are my conclusions. Experimental hypoglycemia has long-lasting effects on blood changes and markers of inflammation in type 2 diabetes. We've shown that asymptomatic hypoglycemia is common in type 2 diabetes, the kind of patients that you and I see very regularly, and they have arrhythmias when they're asleep. At least some of them do. We know that hypoglycemia can cause abnormal cardiac repolarization, and there's trial evidence both for and against a causal relationship, although clearly we can't do the definitive randomized controlled trial. But in the absence of that trial, we might conclude that hypoglycemia is both a marker of vulnerability. I think that's definitely the case, but I hope I've persuaded you that we really need to be concerned about the potential that hypoglycemia has bad effects on our cardiovascular system. Thank you for your attention, and I just want to acknowledge the people who've helped me. Many thanks.
Thank you, Dr. Simon Haller, for the wonderful talk. And you have very lucidly brought out the issues which are associated with hypoglycemia and cardiovascular events. And you have shared your experiences at the lab and bring it to the bedside. So the house is open to comments and questions.
I just want to know, is it true that one of the causes for this increased mortality in the intensive arm was also because of destabilization of these glucose-laden coronary atheromatous plaques because of the rapid glycemic excursion? So that also could have led to the increased mortality.
I mean, I think we don't know for sure, and I'm not overstating this. It's interesting that the ACCORD investigators have always said that they don't think hypoglycemia was the cause, and they've cited marked improvement like that, which may or may not be the case. And I don't know for sure, but I guess it seems to me a plausible hypothesis to explain that. Do I think it's multifactorial? Absolutely, and I think your suggestion is a very good one as well. I think there's lots of things going on, but it's important that we should realize that incredibly intensive control, particularly in patients at high risk, is probably not a good idea, at least not in my view. Thanks.
Any more questions and comments, please?
Doctor, what do you suggest? Means hypoglycemia is more dangerous or hyperglycemia is more dangerous? Both are having risk factors.
So in what way? How do you mean? Give me an example of how you mean.
Say you said, sir, an episode of hypoglycemia may lead patient into cardiovascular event.
It might.
Now, hyperglycemic patient also having the same risk. What is the difference of the risk?
Okay, so you're absolutely right. We know that hypoglycemia is bad for you. I'm not suggesting we should run people high, far from it. But I do think if we have a patient sitting in front of us who's elderly, who's got known ischemic heart disease, we need to ask ourselves, What is the benefit once they've got there? I'm very aware that UKPDS, newly diagnosed patients, we can achieve tight glycemic control without agents which cause hypoglycemia. And there are 2 papers recently being published, I haven't presented those today, which are very interesting. They're observational real-life studies, and they've compared mortality in patients treated with agents which don't cause hypoglycemia with, and they're showing a difference. There's less mortality in the patients who are on medications which don't cause hypoglycemia. I think that is something we really need to be concerned about.
Both ways, sir. We are talking about tight control of HbA1c also, and again we are fearing about the hypoglycemia also. So, do you suggest we should be liberal about HbA1c?
I guess I don't suggest that we should be liberal when we're using medications which don't cause hypoglycemia. We can aim for A1Cs at 6% if they can achieve it with medication which is safe. But I don't think that insulin, you know, in Accord, they tried to get an A1C of 6%. That's dangerous, in my view, and we shouldn't go down that road.
Thank you, doctor.
Now we are running short of time, so we will have a discussion later. I'll request my co-chair to kindly facilitate the speaker.
Yeah, next speaker is Dr. Unnikrishnan. You can always see him in every meeting. And Dr. A.G. Unnikrishnan is CEO of Chalarams Diabetes Institute, a state-of-the-art diabetes hospital in Pune. He heads clinical care, research, education, and also oversees a philanthropic rural diabetes care program at the institute. He always asks me to come over to Pune to see his center, but I didn't have time. I'll come, Unni. He has published the largest multi-center study of subjects with pancreatitis, pancreatic diabetes, in addition to his many other publications. He is also the former editor-in-chief and founder editor of the Journal of Thyroid Research and Practice. He is executive editor of Indian Journal of Endocrinology and Metabolism. So he'll be talking on beyond glucose centrism, CV perspective of diabetes management. Unni, please.
Thank you, sir. Thanks to Dr. Banshi Sabu for the invite and wonderful arrangements. I just like to begin by quoting one of the ancient Indian Vedic texts, which says, this is from the Nasadya Suktam, which talks about the hymn of creation. It asks, who knows? Who here can declare it? How was the universe created? The gods are later than this world's production. Who knows then whence it came into being? So this is one of the very ancient Indian texts which itself brings forth skepticism and the concept of questioning most of the things that we read and learn and understand. And this is vitally important in a meeting like this, where there is an increased focus on cardiovascular outcome trials today, and people talk about sometimes drug A being better and drug B being better and drug C being better and drug A causing better cardiovascular outcomes and drug B causing less hypoglycemia, and the audience is actually confused which drug to use. Well, I must say that I'm not your savior. I don't claim to be. You'll have to decide that yourself, and that's my task today. I will try to introduce some principles of cardiovascular outcome trials so that you yourself can read, understand, and interpret the trials yourself rather than depending on any speaker to give you their opinion, and you can depend on it for your information. So I'd like to begin by saying, what is a CVOT? And a CVOT is, if you take one treatment A versus one treatment B, treatment A could be a drug, treatment B could be a placebo, and after a certain period of time, if there is a predefined primary cardiovascular outcome, it could be CV death, it could be non-fatal MI, it could be stroke, whatever it is, that outcome, whether it is fulfilled or not, or whether it's neutral or not, whether it's superior or not, has to be looked at. Now, one example of a CVOT is the famous HOPE study, which is, I know this is fairly basic, but I think it's important to go back to the basics. So excuse me if you already know this, but if you look at a CVOT like the HOPE study, which looked at ramipril versus placebo, you have death from any cause, you have a relative risk, and you have some confidence intervals. Non-CV death, again you have a relative risk and confidence intervals, and CV event including death. So I'd like you to look at death from any cause, and you can see the confidence relative risk or risk ratio is 0.84, and the confidence interval is 0.75 to 0.75 to 0.95, which is well below 1, which suggests protection. And that brings me to the next part of my presentation, which is a crisis of confidence. As doctors, we must understand what is a confidence interval. And a confidence interval is different from a p-value. Confidence intervals provide a range of the observed effect size. A standard deviation gives also some idea of variation, but the range of the observed effect size can actually come only from the confidence interval. And this is different and better than hypothesis testing or a p-value, which gives you a simple decision. P less than 0.5, is it statistically significant or not? A confidence interval gives you the range, and it also gives you the observed effect size. So let's look at a relative risk ratio of 0.78. This is called the level of the, you could call it the level and or the ratio, but you will see the confidence interval 0.7 to 0.86. These are the limits. Now, if the upper limit of the confidence interval is below 1, it is deemed to be statistically significant. So if I take the weight of every person in this room, and it could be 60, 72, 63, 69, 65, 67, it's all a bit conservative assessment of the weight, you will agree. And if the mean weight is 66 and the 95% confidence interval is 61,71, it means that there is a 95% chance of my next measurement falling between 61 to 71. But what it also means is that there is a 5% chance, 1 in 20, that this result may fall outside this. So that is what it means. So if you look at again the HOPE study result, the level of 0.78, the upper limit of 0.86 is well below 1, which means that it's significant, and it's below 1, it means protection. And if you just subtract 1 minus 0.78, which is a level, you'll get 0.22, and that is a 22% relative risk reduction, which could range from 14 to 30%, which again means that there's a 95% chance of the next study falling between these limits, but there is a 5% chance that this result will not follow this. So coming back to the HOPE study, if you look at the non-cardiovascular death of ramipril versus placebo, it's 1. And when the confidence interval overlaps 1, which means it is 0.85 to 1.26, it means that there is a more than 5% chance that the drug isn't effective. And if it is, so this is statistically non-significant because it overlaps. And if you look at death from any cause, it is 0.84, so 0.75 to 0.95. The upper limit 0.95 is well below 1. It shows statistical significance. And of course, CV death, excuse me, CV death is 0.78. So showing you that the drug can reduce death from any cause, but probably the inference is that the CV event related death is probably driving it because the non-CV death is insignificant. There are some problems with the confidence interval. Again, to quote the ancient Indian philosophy, the first error is called type 1 error, or it's also called the illusory world error. We are often told in ancient Indian philosophy that the whole world is a myth, it is all illusion, it is Maya. So this type 1 error or the illusory world error is very similar. It says that you think there is actually a difference, but there is no difference. The same, the Advaitic concept, if you like, of the same life that animates and activates one person, the same that animates and activates another being. So there is no difference. So that is the illusory world error. The type 2 error, I call it the cynic who got it wrong. The cynic will say, oh, there is no difference, but actually there is a difference. So that's a type 2 error. These are the two errors you'll have to be away from when you look at confidence intervals. And the simple statistic is that 1 in 20 times be prepared to be wrong despite a confidence interval of 95%. The other two issues are, of course, I'll touch upon them. The results should be clinically relevant and it should be externally valid outside the trial population. So let's look at what is called a very landmark study of our times, which is called the EMPA-REG study, as you're all aware. Now this study showed that the non-fatal stroke, this drug did not show a significance, and the hazard ratio was 1.24. Again, showing you that the confidence intervals is 0.92 to 1.67, showing you that the drug did not make a difference. If you look at the non-fatal MI, the confidence intervals are 0.7 to 1.09. Again, it's overlapping one, drug made no difference. If you look at CV death, yes, the drug made a difference. The hazard ratio is 0.62, 1 minus 0.62 is about 0.38, so 38% reduction in CV death. But if you take all these things, and if you look at the 3-point maze, the hazard ratio is 0.86, but look at the upper limit of the confidence interval, it is 0.99. Now, if I ask you that if the Indian cricket team made 199 runs or 200 runs, and do you think 199 is very different from 200? Yes, it is different, but it isn't that different. So you can see that 0.99 isn't too much away from 1. So the drug just made it. So is it the game changer that we've told it is? I leave you to decide, but a drug seems to have just scored some marks. So now I want to go to another topic. Are there two different types of diabetes related CVOT? I often get this question when I go for meetings, not within the hall, but maybe outside the hall when I'm having a cup of tea or coffee with my colleagues. So somebody just told me that I just read a study where the drug reduced and another drug was neutral on adverse CV outcomes. So this is very good news because the ACCORD study and the ADVANCE study and the UKPDS study itself did not prove that glucose control reduced cardiac events. But now you have EMPA-REG study and so many studies showing you that it is reducing cardiovascular events. This is very good news for diabetes. Is it good news? I just want you to find out if you can take heart actually from this news. So let's not compare the UKPDS. I mean, again, this is very basic, but let's not compare the UKPDS or ACCORD or ADVANCE with a CVOT drug trial, because UKPDS, ADVANCE, etc. are trials of glucose control, not of any particular drug. And if a CVOT drug trial looks at the effect of that one drug on CVOT, it doesn't look at glucose control. So again, to put it into perspective, a drug trial on CVOT is an industry-sponsored study. The UKPDS or ACCORD ADVANCE or ACCORD is at least an academic, investigator-initiated study. The CVOT, for example, empagliflozin actually looks at, or you could say TCOS or whatever, it looks at the effect of that drug on CVOT. The UKPDS looks at the effect of glucose control or A1C on CVOT. The outcome in a CVOT is driven by regulation. The outcome in a UKPDS is driven by the duration. That's a very interesting question. In a CVOT, it is an event-driven study. So how do you, if you have more events, you can close the study very quickly. So the study gets over in 2 to 3 years. Now how can you increase the number of events? Two ways. Either you increase the number of patients or you increase the number of high-risk patients. You get more events and you get quickly statistical significance. So you will find that these studies are shorter. Whereas UKPDS, you will find that this is not an event-driven study. It is a duration-driven study. So you will find the duration is longer. Ideally, we need to have a study which looks at both event as well as duration, but such studies are expensive. But ideally, you need that. Now, the results of any study looking at CV outcome, it could be sitagliptin or empagliflozin, anything, it shows that drug is CV event safe or neutral or better. It doesn't show that glucose control is better, whereas the UKPDS showed that glucose control reduced microvascular events. So we've talked about what is a CVOT. Let's look at what is not a CVOT. So this is another area where people get confused. Some people say, so what if a dedicated CVOT is not available? We've got analysis of all the phase 2, phase 3 studies showing that it's okay. So just to put the point that secondary analysis of a glycemic control study is not a CVOT. So there are two types of studies here. One is a glycemic efficacy study. For example, if you do a study of sitagliptin to control blood sugar, that's a glycemic efficacy study. If you look at the effect of sitagliptin versus placebo in a long-term study, look at cardiovascular outcomes like in the TICOS, that's a CVOT. A glycemic control study cannot be called a CVOT because a glycemic control study just asks the question, is this drug versus placebo better at controlling sugars? A CVOT doesn't ask that question. Is this drug versus placebo when used to control sugar good at cardiovascular outcomes? A glycemic control study has small sample size, maybe hundreds. A CVOT study has got thousands of sample size. A glycemic efficacy study is just a short study, maybe 6 months to 2 years. CV outcome study, typically 3 years or more. The inclusion criteria for a glycemic study is fairly focused because you want to test a particular population, whereas a CVOT is a more broad. The most important thing is the endpoint. We published this in the Indian Heart Journal, and this article was cited by Dr. Cefalu in Diabetes Care as well, because the end point of a glycemic efficacy study is glucose control. The end point of a CVOT is a CV outcome. The expectation of a glycemic control study is, did my study improve or not improve blood sugar? The expectation of a CVOT is, did this drug versus another drug change the CV outcome? So we can't say that, okay, we are taking all the glycemic control studies, we are going to do a secondary analysis and therefore it reduced cardiovascular events, so it's cardiovascular safe. That's not a CVOT, that's nothing. It's not nothing, but it's not a CVOT. So a CVOT is very different from a glycemic efficacy study, and we as doctors, we need to know this, because when we are shown a study, we tend to look at the conclusion, maybe the last line of the conclusion of the abstract. And then we depend on speakers to tell us what to prescribe. But I think it's time we took some ownership for reading the study and looking at all this for our patients. There's a bonus example. I don't know if I have enough time. So this is the bonus example. Somebody says, I took this oil slicker pill. It reduced my cholesterol by 40%. I felt that the oil poured through my urine, stool, sweat and tears. I think it's the best medicine to prevent heart attacks. I tried it on myself. So is this a way? This is an anecdotal experience. So, but the question I'm asking is not that. Question I'm asking is, even if this drug can control a cholesterol level, does it mean that it can reduce a cardiovascular outcome? It doesn't mean that. So I'll just put into perspective the difference between a surrogate outcome and a real outcome. This is an old clofibrate story. It looked at cholesterol level change. Clofibrate reduced cholesterol by 9%, placebo increased it by 1%. Good. Clofibrate reduced cardiovascular non-fatal heart attacks by 5.8%, placebo 7.2, sorry, 5.8 per thousand with clofibrate had a non-fatal heart attack, 7.2 with placebo had. So clofibrate less non-fatal heart attacks. If you look at fatal and non-fatal heart attacks, very good result. Clofibrate only 7.4 fatal plus non-fatal heart attacks per thousand, placebo 8.9, so very good result. Clofibrate numerically less. But if you look at death, clofibrate caused 6.2 deaths per thousand, whereas placebo caused only 5.2. So showing you that cholesterol is a surrogate marker and cardiovascular event, death or CV mortality is a real marker. So always look for a hard outcome like a CV death or mortality when you read a paper. So let's look at, before I end, I think I have 3 minutes 50 seconds. So before I end, I just want to show you clinical significance versus statistical significance with this clofibrate story. Now deaths with clofibrate are 6.2 per thousand. Deaths with placebo 5.2 per thousand. So excess chance of death with clofibrate is 6.2 minus 5.2 by 5.2. So 19% more deaths with clofibrate. You'll agree that this is clinically significant. Let's look at statistical significance. Deaths with clofibrate 6.2, placebo 5.2, p-value less than 0.05. So this is statistically significant because there is a low chance of this difference being due to chance. That means there's a low chance of type 1 or alpha error or of this being an illusory world error. Now supposing Supposing the doctors had not taken thousands of patients, supposing they had taken only 200 patients instead of 2,000 patients or 5,000 patients, you must understand that if the patient number goes up, the confidence interval go very narrow. So you get better results. But supposing they took only 200 patients and they found that 6 people died in the clofibrilate group, 5 died in the placebo group. And if the authors had concluded that this could be due to chance, it could be a type 2 error, if they had concluded that, that means they would have committed a type 2 error. They would have become a cynic saying there's no difference, but actually there was a difference. So therefore, it is important to look at studies with larger numbers. So ladies and gentlemen, I'd like to conclude that what is a CVOT I've discussed with you. I've looked at the confidence intervals, how to interpret them. I've looked at the difference between a UKPDS model and industry-sponsored CVOT. I've told you that a glycemic efficacy study, secondary endpoints on CVOT is not a CVOT. It's a glycemic control study with some exploratory endpoints. I gave you an example where a surrogate outcome is not a real outcome. I'd like to go back to this Vedic hymn which I said. Who knows who here can declare it? How was it created? The gods came later than this world's production. So the gods came after the world's production. Who knows when this world came into being? And then this hymn goes on to say, He, the first origin of this creation, whether He formed it at all or did not form it, whose eyes control the world in its highest heaven, He verily knows it. And the last line, the conclusion of the abstract is most important, or perhaps He knows it not. So this is a typical creation myth. If X has created the world, who created X? So again, I have not created this. All this has existed before me. So do not depend on me. I am not a savior, but you should go back and remember who created the creation. And I'd like to go back and point all the points I said before. CVOT, confidence interval, glycemic efficacy study versus a CVOT, and of course, surrogate outcomes are not real outcomes. I have 40 seconds left, but ladies and gentlemen, thank you so much for listening to me.
Thank you, sir, for the wonderful talk, invoking the principles of Advaita. You made us explore the unexplored, and you have dissected what was real, which was apparent, and which was apparent, which was real. Thank you, sir, for the wonderful talk. And the house is open for some comments and some questions, please.
So, with the permission of the chairperson, Dr. Onikrishnan, if you can suggest, do you think there can be any changes brought to the model of CVOT that is existing?
There are several models. I think the first important model is the CVOT itself is increasing the cost of medicines. And the CVOT came out because of the rosiglitazone story. So in my mind, there is no need to do a CVOT because the goal of CVOT is not to show whether the drug improves outcome anymore. It's just to show that the drug is not inferior. If the upper, it doesn't matter if the the confidence interval upper limit is below 1 or above 1. As long as it is below 1.3, the drug is shown to be neutral or non-inferior. So the goal is non-inferiority. Isn't that really an inferior goal when you look at the fact that you are increasing the cost of medicine by doing these huge CVOTs, especially for a country like India? But I think a CVOT is still important from the regulatory point of view because we need caution. I think the future is going to be of real-world evidence, of pragmatic clinical trial models, and where they are done in a practical setting. And I don't know if it's applicable, but from the McMaster University, there is a model called a single patient randomized control trial. It's called the NF1 trial, in which a doctor looks at one patient and sees it's good for short-term diseases. It's unfortunately not good for diabetes. But I think newer, innovative models to look at CVOT will bring down cost and bring the drug quickly to the patient. Of course, we'll have to look for side effects.
Sir, very good lecture. Suppose there is a situation where the confidence interval, both the upper limit is less than 1, but the p-value is more than 0.05. Then which one we should consider?
So usually the confidence interval less than 1, the p-value is going to be below 0.5.
Yes.
I'm not aware of that dichotomy can occur. And if that case, the confidence interval seems to be more robust, but I don't think that can happen, but I'm not aware of it.
I've seen in, I can't remember, but I've seen in some cases.
I think it may be possible in certain analysis. If you look at it, a confidence interval is better than a p-value. That's a take-home point. But I'm not aware as to the exact depth of the statistical answer to your question.
Okay.
Thank you. And if there are no questions, I think we can close the session. And I request my colleague Tiwari to honor Unikrishnan.
Now again it's time for an oration. We have Dr. Suman Shah oration, and to chair this session, very important oration, we have Dr. Nitin Suman Shah, who is son of Dr. Suman Shah. Dr. Suman Shah was one of the leading physician of this state of Gujarat and Ahmedabad. He died before 15 years in 2003 at the age of 83. He was the first one who started here in private sector a Gujarat diabetes clinic, and at the same time Dr. O.P. Gupta is a contemporary in civil hospital who started in public hospital a diabetes clinic. Dr. Suman Shah was the first one to start a Gujarat Diabetic Center in private. So to chair this session we have Dr. Nitin Suman Shah for Dr. Suman Shah oration, and we also have Dr. Anil Kulsesta, who is a president of Association Physician of Ahmedabad. I invite Dr. Anil Kulsesta and Dr. Nitin Shah to be on the dais.
First of all, thank you for Bansi and Bansi team that I am here and hall is in the name of my father. He was a great man, not because of I am a son, but if you ask for anybody in Gujarat, everybody knows my father, and he has dedicated his life in medical field. He has started diabetic clinic first in garage in our resident, and then he has developed the Gujarat Diabetic Association. That way, Dr. Gupta was also very renowned and other, and he was at civil hospital. And because of Dr. Gupta and Dr. Suman Shah, developed the diabetes in Ahmedabad. I am very grateful again to Bansi Sabu. He is looking after me as a younger brother, and I am always with him.
Good evening, sir. Good evening, everybody. Now I invite Dr. A. Muruganathan from Tirupur for this oration. He is the emeritus professor, the Tamil Nadu Dr. MGR Medical University. He is Dean, Indian College of Physicians from 2016 to 2017. He was President Hypertension Society of India 2015 to 2016. He was past President of API 2013-2014. He received BC Roy Award from President of India in 2005. He received Best Performing Doctor Award from Tamil Nadu Government. Received Lifetime Achievement Award by Tamil Nadu Dr. MGR Medical University and Savita Medical University, KG Foundation and Dr. Mohan's Diabetes Foundation.
Respected chairpersons, Nitin Shah, Dr. Anil, and my brother Dr. Bansi Sabu, and my dear brothers and sisters. At the outset, I must thank Dr. Bansi Sabu for having chosen me to deliver this prestigious oration. At the same time, I must congratulate Dr. Bansi Sabu, who is recognizing the people from Ahmedabad, and especially Dr. Suman Shah, who was the first diabetologist from Ahmedabad. And I see Bansi Sabu not only academically but also socially is very active and popularizing the diabetic awareness among the public of Ahmedabad. No wonder he is the successful clinician in Ahmedabad. Thank you, Bansi brother. There is nothing to declare. If somebody wants to give me donation, I accept it. Thank you. The agenda of my talk, the topic I've chosen is trans fat elimination. After hearing all the serious talks like hypoglycemia and the CVOT trial, CVOT outcomes, I'm going to talk on a subject, trans fat elimination. It's not only public health oriented, it is also clinician oriented topic, which I think we must always practice, also talk to people. My agenda will be introduction, history of trans fat, what exactly are the trans fats and health risks, why to eliminate trans fat, international efforts, WHO plan, the May 2018, and scope for action, Indian regulation, summary and conclusion. As I was talking about the trans fat elimination, yesterday we had a meeting of the healthy diet where all the associations were involved. The Indian Medical Association also had taken an important part. Of course, the non-communicable diseases are the leading cause of death and were responsible for an estimated 39.5 million of the world's 54.7 million deaths in 2016. CVD were the leading cause of NCD mortality in 2016 and was responsible for nearly half of the NCD deaths. Diets high in trans fat increase heart disease risk by 21% and deaths by 28%. WHO recommends that the total trans fat intake be limited less than 1% of the total energy intake, which translates to less than 2.2 grams per day with a 2000 calorie diet. Of course, this is the major cause of death, NCDs. You can see NCD death 60.5 lakhs. And of course, the premature mortality due to heart disease, especially 40 to 69 years, if you see, more than 43.7% total deaths because of the heart disease. Inter-heart study says there are 9 risk factors for the heart disease. One is smoking. The second one is dyslipidemia. The dyslipidemia may be high LDL and low HDL, high blood pressure, diabetes, abdominal obesity, fruits and vegetables, exercise and alcohol. Something interesting about history of trans fat. It was in 1890 Paul Sabater developed the chemistry of hydrogenation, only hydrogenated vapors. In 1909, Procter & Gamble bought the rights to Norman's patent, and PG developed Crisco. It's a very popular thing. First hydrogenated shortening, hydrogenated cottonseed oil. And the popularity of hydrogenated fats increased until 1960s. People thought the trans fats are more healthier than the saturated fatty acids. So all the industries started replacing saturated fatty acids into trans fat. But in 1987, the Center for Science in Public Interest defended trans fats in their newsletter. But 1992, they started speaking out against the trans fat, and 94, they declared it is not good. And there were about 30,000 deaths a year. Okay, coming to the fats, it's a basic thing, but still, what are the types of fat? One is saturated fat, the other one is unsaturated fat, which is again monosaturated, polyunsaturated, and trans fat. A little bit of biochemistry. The unsaturated fatty acids can be cis or trans. Cis is H atoms on the same side of the double bond. Trans is H atoms or on the opposite side of the carbon double bond. The allylic acid, which is hydrogenated vegetable oil, and oleic acid is olive oil is cis position. The difference is melting point is more in the hydrogenated vegetable oil. The same chemical formula as many other unsaturated fats but are in transposition, occurs naturally in meat and dairy products from ruminants, cattle, sheep and goats, etc. Makes up only 2 to 5% of the total fat. Whereas the trans fat in hydrogenated vegetable oil can be up to 45 of total fat, shortenings 30% and margarine 15%. This is again a clear vegetable oil. When it is hydrogenated becomes a solid or semi-solid. The trans fats made in cooking, one of the important message I would like to convey to all of you, when the clear cooking oil is repeated heating by repeated frying can become trans fat. See, many people, many houses, including our medical doctor's house, maybe Minal and Divya also, Ashok can vouch for it. In our house, when we use oil, we use it. We don't want to throw it. But by using that, you will definitely get trans fat. So the message what you have to convey to your patients, take limited oil, use it and throw it. I read a history. In those days, the kings, when they make one puri in the oil, they throw it. Again, for the second puri, they have a second cut of oil. This history, I read it. And they know. And when they throw the oil, there will be people waiting there to take the oil for home. So even those days, they understood, probably because of science originating so early. Coming to the which foods contain industrially produced trans fat. Industrially produced trans fatty acids can be found in baked and fried foods. Example, donuts, cookies, crackers and pies, pre-packaged snacks and foods, pre-mixed products such as pancake and hot chocolate mix, and partially hydrogenated cooking oil, vanaspati and margarines, and fats which are often used at home, in restaurants or in the informal sector such as street vendor. Especially in street vendors, they use this. So trans fats everywhere. So these are the main products which we have used: biscuits, pastries, cakes, pies and cookings. One of the important thing is all of these products can be made without industrially produced trans fat. This is the point you must understand, and make sure your friends, your relatives who are running the hotels or restaurants, ask them to change the trans fat. I am coming to that. Why people use trans fat? Why trans fat? There are commercial advantages. One, increases the bulk, longer shelf life, cheaper, decreases rancidity, decreases need for refrigeration, forms a semi-solid because of increased melting temperature, and more desirable texture in the baked products, can replace butter and lard. Foods containing trans fats are considered kosher, can be consumed by vegetarians and people who follow religions banning certain animal products. So that's how this was very popular. And what are the health risks? The impact of the fats on the body: first, it push up the level of LDL, decrease the level of HDL, increase the level of triglycerides, increase vascular endothelial dysfunction, may increase insulin resistance. The risk to health of higher trans fat intakes: clear evidence of increased risk of coronary heart disease, angina, heart attack. Some evidence suggesting an increased risk of type 2 diabetes, endometriosis, and then researchers showed that increase in trans fat may cause increases in infertility in women, causes more inflammation, obesity, gallstones, Alzheimer's disease, and possible increased risk of prostate cancer and breast cancer. So these are the risks of the trans fats. And impact on population health. The meta-analysis of 5 large-scale prospective population studies found that 24% increase in CHD risk associated with higher TFA intake. And gram for gram, the trans fatty acids carry 5 times the risk associated with saturated fats. So compared to saturated fats, it has got 5 times the risk. And every gram increase in the average intake increases coronary heart disease or cardiac disease deaths by 5%. The trans fat consumption and health inequalities. There is concern that children and young people and those on low incomes are consuming worryingly high levels of TFAs in deep fried takeaway foods. So all takeaway foods, fast foods contains trans fat. Even the street, I already told you, even the poor people, when they reuse the oil and use that, they get trans fat. A recent study in Tower Hamlets suggests that some individuals are consuming 6 to 12% of food energy as trans fats. The high intake among young people and deprived population was a key concern in the Denmark legislation. Then TFAs in fast foods. 1 in 6 meals is eaten outside the home. The number of takeaways outlet is rising by about 8% a year. Main customers are children and young people and those on lower incomes. Cooking practices are vary greatly. Very high trans fat acid levels can result from reheating cooking oil even when initial levels are low. Deep fat fryer in small takeaways are a particular concern. So I always say fast foods takes faster to grave. So avoid fast food, and fast food contains trans fat. So you must talk to the people and tell them once in a way you can take fast food if your wife is not well, if you have some problem, but not every day. And whenever people go, it is a fashion to stop near the fast food shop, collect it and go to the airport, and even in the flight they take fast food. I see many people, because when they don't get food served in the aeroplane, they buy fast foods and they use it. All educated people also. So that practice you should avoid. And I told them today in Indigo, I wrote a report. They said, your comments, I said, please serve fruits. No aeroplane or aircraft serves fruits. They only serve fast foods. So I wrote to them strongly that you should serve fruits. Top 15 countries with largest number of chronic heart disease due to high TFA intake: United States, Canada, Germany, Japan. Low and middle income countries like India, Egypt, China, Pakistan, Russia, Mexico, Brazil, Iran, Ukraine, Bangladesh and Indonesia. The trans fats and health risk. The New England Journal of Medicine says, from a nutritional standpoint of view, the consumption of trans fatty acids results in considerable potential harm and no apparent benefit. The National Academy of Sciences, NAS, says trans fatty acids are not essential and provide no benefit to human health. That dietary trans fatty acids are more deleterious with respect to CHD than saturated fatty acids. There is no level of trans fat consumption that can be considered safe. Even a small increase in trans fat consumption increases risk of CHD. That is why the lipid guidelines of India and people say zero trans fat, not even 0.5%. Why to eliminate trans fat? The artificial trans fat is a toxic chemical that increases the risk of heart attack and death. 540,000 people die from artificial trans fat intake each year, and zero. Foods for which artificial trans fat is necessary is zero. International efforts. See, people in other countries, they realized the toxicity of trans fat, and Denmark was the first country to ban the trans fat and save lives. The first world to legislate against trans fat since 2005. They said maximum level 2 grams trans fatty acids per 100 gram of fat. No strong objection from the industry. So when they introduced the legislation in Denmark, all the industries supported, and ban followed by a decreased deaths due to heart disease. They proved that the heart disease decreased, and estimated reduction was 14.2% deaths per 1 lakh. Then other countries followed: Austria, Georgia, Hungary, Iceland and Switzerland. In US, the New York State, they introduced first. The people living in counties with artificial trans fat restrictions had a 6.2% greater decrease in hospital admissions for heart attacks and strokes than in people in countries without restrictions. In the United States, each state has got different rules and regulations. So New York was the first country to introduce. Okay, when I said trans fat to be eliminated, what healthy oils should be used instead? The partial hydrogenation oil can be replaced by oils rich in polyunsaturated fatty acids, followed by oils rich in monosaturated fatty acids. Oils rich in few fats include sunflower oil, corn oil, soya bean oil, fatty fish, walnuts and seeds. And MUFA include canola oil, olive oil, peanut oil or oils from nuts and avocados. The choices used in many countries will be influenced by availability, cost of the replacement, alternatives, and the oil industry's capacity to innovate. You see the impact of replacing the trans fat. A 2% higher intake of trans fat increases the cardiac disease by 23% and CVD mortality by 34%. So by impact of replacing 2% of dietary energy with saturated fatty acids, you get 17% risk reduction, with MUFA 21% risk reduction, with the polyunsaturated fatty acid 24% risk reduction. So they proved by changing the oil from the trans fat to the polyunsaturated fatty acid, definitely risk reduction is reduced. The global scenario, by the end of 2018, 23 countries will have set mandatory limits on industrially produced trans fat, on banned partially hydrogenated oils. You can see every country says less than 2%. In India, the limits to trans fat is 5% in fats, oils and emulsions. We had a talk, we had a meeting with ICMR, WHO in Delhi, the government of India. Now we have come out with protocols. We are going to reduce even further, because we were using more than 8%. They agreed 5%. Now we have requested them to come to 2%. What is currently being done? The partial hydrogenation plant oils without production of trans fat. Okay, there is scientific improvement. When the partial hydrogenation plant oils, the amount of fat, trans fat, can be reduced by varying the pressure, much higher pressure. Or under normal processing condition, trans fat makes up around 40% of the total fat, whereas under high pressure conditions, trans fat makes up only to 17% of the total fat. Can then be mixed with non-hydrogenated oil to make margarine containing only 5 to 6% of trans fat, can be considered trans fat free. Can also possibly change temperature and length of time for hydrogenation to control trans fat. Many food companies and fast food restaurants are voluntarily reducing or eliminating trans fat from their foods. For example, Walt Disney Land will get rid of trans fats from their theme parks by the end of 2007. Crisco, now owned by J.M. Smucker Company, released the trans fat free version of Crisco. Now have removed all but 1 gram serving of trans fat from their products. These have replaced the trans fat free version. The artificial trans fat can be eliminated. Experience from food manufacturers shows artificial trans fat can be eliminated. It may take 2 to 3 years for certain foods, but replaced with healthier alternatives without altering the taste or increasing cost. The two main things for the food industry: it should not alter the taste, at the same time it should not increase the cost. WHO planned to eliminate industrially produced trans fatty acids from global food supply. WHO calls on government to use replace action package to eliminate industrially produced trans fatty acids from the food supply. I'll tell you what is replace. Implementing the 6 strategies, actions in replace package will help achieve the elimination of trans fat and represent a major victory in the global fight against cardiovascular disease. What is this replace? Replace is RE. Review the dietary sources of industrially produced trans fat and the landscape for required policy change. P. Promote the replacement of industrially produced trans fat with healthier fats and oils. L. Legislate or enact regulatory actions to eliminate industrially produced trans fats. Assess and monitor trans fat content in the food supply and change in trans fat consumption in the population. C. Create awareness of the negative health impact of trans fats among policymakers, producers, suppliers and the public. Enforce compliance of policies and regulations. So WHO has sent this replace package to all the governments, and the another organization called Vital Strategics resolved to save life. Both of them together, they are doing this trans fat elimination all over the country, and I am one of the senior advisor and consultant of the the Vital Strategy. So we are taking this across the country and also globally. And when the May 2018, when the replace came, every journal, every article has said, the CNN says WHO calls for elimination of trans fat in foods by 2023. And every association also now taken up this replace package, and they are implementing. As I said, Resolve will work with local, national and global governments to help scale up proven strategies to reduce and eliminate exposure to artificial trans fat and increase availability of healthier alternatives. This can be done through mandatory labeling, limits and restrictions. The source of trans fat globally are varied and there is currently no systematic effort to measure or eliminate its use. Resolve will support the tracking of artificial trans fat in the food supply. In fact, Resolve is looking for an organization who has got the foreign currency FCRA certificate. If somebody has got FCRA certificate, if some NGOs or some medical organization is there, they are willing to fund the organization to spread the awareness. So if anybody is there, if anybody also would like to do, if only you have a FCRA certificate, we will help you to get the funds for promoting trans fat elimination. The United States in 2015, FDA determined that the partially hydrogenated oil, the major source of artificial trans fat in the food supply, are no longer GRAS, that is generally recognized as safe. For the majority of users of PHOs, US FDA has set June 18, 2018 as the date after which manufacturers cannot add PHOs. To allow for an orderly transition in the marketplace, FDA is extending the compliance date for these foods up to January 2020 and has taken steps to remove artificial trans fat in processed foods. Why should government prioritize? Because replacing trans fat with healthier oils is a low-cost way of government to save the lives. So WHO recommends trans fat elimination as a cost-effective intervention for low and middle income countries, and governments can eliminate the cost of 7% of cardiovascular disease globally with this low-cost investment. The scope of action: reduce recommended maximum TFA intake to less than 0.5% food energy across the population, as Denmark has done. Shift from voluntary to mandatory. In our country, sometimes voluntary may not work, so you should have mandatory. And then the industrial trans fat in all ban all industrial trans fat in all manufactured foods, and labeling and specific group of foods. So I request all of you to create an awareness among the patients and public. Whatever they buy, they should see the label, whether it is chips, whether it is oil, whether it is any snacks, cookies, biscuits. Ask them to look at the label, and the label should say what is the percentage of trans fat, what is the percentage of cholesterol, and if that is not there, you can always report to the consumer court. Improved guidance and tougher regulations for providers of foods eaten outside the home. Improve monitoring of TFA intake in specific subgroups, example children, low-income groups and ethnic minorities. You tell all your children fast food is not good and don't encourage them, because nowadays, by a phone call, people will come to your house and deliver the goods. So everybody, the mother and father, parents are very happy, especially when lady doctors come out for the conference. They give the phone number to the son, and the son will ring up the fast food and it will be delivered. And there is a competition, how fast he is coming. The fast food people are coming fast, and they also met with a lot of accidents. So I think we must discourage this. And regular mini surveys of TFA content in fast foods. Indian regulation. The good news is the Indian regulation, as I said, we had a meeting. The food safety and standards in 2013, not more than 10% by weight of the following fats, oils and emulsions: intensified vegetable fat, bakery, industrial margarine. In 2015, amended to less than 5% and extended time up to February 2017. As I said, now we are asking for less than 2% and front of pack labelings and TCA claims. So I request all of you to create an awareness among the government officials and also the authorities in locally, and ban all the fast foods with TFA more than 1%. As summary and conclusion, has no physiological role akin to food toxin. Elimination of industrially produced TFA is feasible and achievable. Adverse effects cannot be reversed by other lifestyle factors like physical activity. So you can say the cholesterol increase, you can do physical activity, you can reduce. But the trans fat, you cannot reverse by lifestyle activity, especially physical activity. During the past decade, various policy actions, mandatory or voluntary, TFA labeling, reformulation, national and local TFA prohibitions have been implemented by countries aiming to restrict the TFA content of food and reduce TFA intake in their population. Globally, efforts are being made for complete elimination of trans fat from the food supply. The gentleman from Finland will vouch for me. They also in Europe, they are following this trans fat elimination completely. A comprehensive approach to tobacco control allowed to make more progress globally over the last decade than almost anyone thought possible. When the tobacco control was there, they never thought it can create such a awareness. A similar approach to trans fat can help to make that kind of progress against cardiovascular disease, another of the world's leading cause of preventable death. With little cooperation and efforts, we can easily eliminate industrially produced TFA in India. Together, we will achieve freedom from trans fat. Thank you very much. Learning is beginning of health. Learning is beginning of wealth. Learning is beginning of spirituality. Thank you for your attention. Thank you very much.
Wonderful oration, sir, and very timely, which is right now it's the real problem. And definitely this low-cost intervention will save many lives. Thank you very much, sir.
I'm very...
No, this is not working perhaps. Now it is working. Yes, yes. Thank you. A very nice lecture. It is very informative and very useful to reduce the cardiovascular diseases. In army, they have stopped using dalda, which was trans fat. So, like this, central organizations who were preparing food at one place, they have gradually stopped. So that is very good. But even the rich families find it difficult to throw away the costly oil once it is used for frying. And the reason is that it costs to them. So the suggestions that you have made are not implementable.
I think we must start from our home, sir, because in our own medical doctor's home, we must start using that, and then tell the patients also.
Is very small percentage.
No, I'm saying we are the role model. We can tell everyone that we should not use that, and especially in small villages, you know, they reuse, and not only trans fat, so many other toxic substances are there. Trans fat as such is only 3.7% increase. The other toxic substances are there in using. So that's why I request all of you to take this public health oriented topic, discuss with people, try to reduce trans fat, and request your children not to take fast foods, and we also follow the same principle. So this is the eye opener for because every country has started. Denmark was the first one to start. Now all the countries have started, and even in India we are going to implement, and we are going to bring strict legislation to reduce to 2%. In 2018. Yesterday we had a healthy food discussion at Delhi. The IMA also is involved, and so many other professional organizations, commercial organizations also are involved. Thank you, sir. Thank you for your...
Thank you.
So we are not military, but we'll try to follow the military group, sir.
Very thankful, and I want to join with you. Recently I was in USA.
Sir.
Now so many awareness of tobacco, and now they are going for healthy food. And here I want to establish with you and Bansi for awareness of this junk food and other thing. I am thinking to have a restaurant healthy food also.
I think Bansi Sabu in Ahmedabad can start a restaurant for healthy food, and he can start chain of restaurants. Bansi, you are good in all the social activities, so start one role model healthy food restaurant, and where people can come and eat. It's a free, diabetic free, salt free. It is good for kidney friendly, heart friendly, and romantic also.
We can do anything. Thank you very much.
I would also like to call upon Dr. Pratap Jethwani sir to felicitate our chairpersons. For the next session of our keynote address, would like to call upon Dr. Asa Ensa and Dr. Reema Rao to chair the session further.
Yeah, good evening. The keynote address is going to be delivered by Dr. Shaukat Sadikot. Actually, he doesn't need any introduction, but it is my pleasure to do it. He is going to talk on diabetes neuropathy, clinical application on new research. Dr. Sadikot is Vice President of IDF and by this immediate past president of IDF. He is member of Scientific Committee of Metabolic Syndrome Institute, member Executive Board of International Atherosclerotic Society, co-chair of Asia Pacific Symposium, and so many more. Okay, sir says no more introduction.
Well, thank you, Asha. Thank you, Eva. I'm sorry Shashank could not be here. I'm not going to take his lecture. I'm going to take my lecture, which was meant for tomorrow morning, so I can sleep late. Now, I know the topic given was recent advances, but very frankly, what I'm going to do is concentrate a little bit on the problems of peripheral neuropathy in diabetes, because that, I think, is a little more important than just learning about new things and not working on them. So the question that I want to ask is, should we be getting nervous about our nerves? Anybody? Should we be getting nervous about the nerves? Yes or no? No? Okay. Well, why are we even bothering about diabetic nerves? Now look at this. You can see that diabetic neuropathy is the most common complication of diabetes mellitus, greatest morbidity and mortality, and a huge economic burden to a person with diabetes. I know that just now Professor Murugathan were talking about what's happening in Denmark. Remember, what happens in Denmark, as even Hamlet said, doesn't happen in the rest of the world, but it definitely doesn't happen in India. Everything is free in Denmark. Nothing is free in India. And therefore, you have to understand that what works in Scandinavia, Jakob, I'm sorry to say that, but what works in Scandinavia may not necessarily work anywhere else in the world. But in any case, it is the most common form of neuropathy in the world and accounts for more hospitalization than all other diabetic complications combined, and is responsible for 50 to 75% of non-traumatic amputations. The major morbidity is foot ulceration. Now look at this. Neuropathy increases the risk of amputation by 1.7-fold, 12 times increase if there is deformity, and a 36-fold increase if there is a history of prior ulcers. So the question really comes in is, let's not wait till a small ulcer forms and then try and treat it. Our point is, let us do something to see that it doesn't occur. And I think we know a lot about what to do and what not to do. Unfortunately, I'm going to ask you a question as to why we don't do it. That is the problem. Why is it that we don't do it, although we know we don't need new knowledge? We know we have to prevent diabetic foot problems, but the problem is we don't do anything about it, and that is something that all of us have to think about. Why? Now, I think we have come a long way from the time in the Abbas Papyrus, which recommended a treatment for diabetes consisting of a liquid extract of bones, grain, grit, wheat, green, lead, and mud. because we had nothing else to do. We know a lot more. And like I always maintain, and in fact, Bansi told me, boss, don't say too much about it. But I want to know one thing, and that is that in 2011, remember, when the International Diabetes Federation came out with its atlas, there were a lot of data inside, a lot of figures, a lot of things and everything. But one thing that stood out was the fact that one person died because of diabetes-related complications every 7 seconds in the world. Now in 2015, after 4 years when we came out with the IDF Atlas, what did we find? One person died every 6 seconds. Now people sit back and think about it. You may think 1 second here and there doesn't matter. But remember that it's about, I think, one person dying every 16 seconds in the US, and I'm sorry, every 6 seconds in the US and every 3 seconds in Western Europe. So basically in India and most of the world, a person dies every second. Forget that part. I want you to just sit back and think that between 2011 and 2015, new drugs came out, new knowledge came out. How many conferences did you all attend? How many lectures did many of us take? And yet, what is it about? For the person with diabetes, things became worse. Instead of dying every 7 seconds, somebody was dying every 6 seconds. So I just want you to sit back and think as to why that is so. It is not a question of just, oh, I know so much. Oh, I can do this, I can do that. No. Nothing is important to you and to me unless it translates into being beneficial to the person with diabetes. Today, as you know, we don't talk about diabetics. It's a swear word. I made that when I was in the president of the IDF, and the WHO accepted it. You do not use a word diabetic for anybody. There are no diabetics in the world. There are just people with diabetes. Now you would say, oh, come on, this is just English. You know, Shaukat is showing off his English knowledge. Well, I'm not. Think back. Calling somebody a diabetic and thinking of him as a person with diabetes will make a huge difference to how you manage that person with diabetes. And that is very important. Like I said, a lot of knowledge, but look at this. Every 20 seconds, a person loses a limb because of diabetes. Today in India, after accidents, the largest cause of lower limb amputations is diabetes. The question is, what are we doing about it? It's not just a question of knowing what's the latest and what's happening and, oh, come on, everything, let's do this and let's do that and this is the latest thing. No. It's a question of translating that knowledge right from the academic towers of, you know, the ivory towers, I call it, of academia, to the people, to the ground reality. You have to think, why are you here? Why are you getting this knowledge? It is to help people with diabetes. If you're not going to be able to help people with diabetes, all your knowledge, in my opinion, is utterly useless. Let me be very frank with you. So can we prevent diabetic neuropathy? Prevention and early optimal management, as you know, if you could prevent diabetes, fine. But can we at least prevent, slow down the, delay the onset, slow down the rate of progression? Can we do that? Well, I don't know. I hope we can, but remember one thing. They studied people with idiopathic sensory neuropathy, and 30 to 50% of them already had impaired glucose tolerance. And many people with impaired glucose tolerance already have symptoms of neuropathy. So, what are we going to do? Test everybody for IGT now? No, I don't know. The question really is, I think we leave it to you to decide. Now, what is diabetic peripheral neuropathy? The presence of symptoms and signs in people with diabetes after exclusion of other causes. Fine. It may be silent and go undetected until it comes with a massive problem, or it may present with clinical symptoms and signs that, although non-specific and insidious, mimic many other things. So now the question is, what is diabetic peripheral neuropathy and how will you diagnose it? Well, the true prevalence is not known. 25% of the people attending a diabetes clinic volunteered symptoms which suggested they had neuropathy. When you tested with a monofilament, 50% had it. When you used a lot of latest equipment, 90% had symptoms of peripheral neuropathy already. So obviously, it is a most common form. And what are the types? Again, I'm not going to go into that, but basically, you have focal and multifocal and symmetrical neuropathies, autonomic neuropathies, and diabetic peripheral neuropathy. As you know, you have large fibers, you have small fibers, and initially when the large fibers are affected, you lose muscle control, touch, sense, vibration, position, perception, and then when small fibers are affected, cold perception, pain, warm perception, and pain again comes in. And this is very important because the small fibers are the majority of the fibers in the periphery, and they are the ones who are the most affected. And these are your symptoms for large fiber and small fiber. Large fibers interfere with normal life and risk of falling and fractures, while small fibers produce symptoms and leads to morbidity and mortality. What are the symptoms? You all know about it, painful and non-painful. But here is one thing that, frankly, most people ignore, but it's a very early symptom. How many of you all ask patients about allodynia? Anybody? What is allodynia? Very often, sometimes the patient comes and complains that, you know, doc, I'm fine otherwise. But when I go to sleep and I put on a little blanket or I put on a sheet to just cover me up, my feet start burning or hurting. That is a very, very important sign of peripheral neuropathy. But we unfortunately ignore it. That's the problem. So allodynia is very important. So what do you get? You have diabetic symmetrical portal neuropathy. You can get painful symptoms. You can get neuropathic deficits, impairment. The quality of life goes down. Believe me, it does. Foot ulcers occur. You can get infections. You can get Charcot's foot. You can get surgery and amputations take place. The cost, of course, goes up. And again, the mortality goes up. So all this is a problem. And this is something you have to look into. Well, you have pain. We went to all this. Remember, foot ulceration, at least 50% are totally preventable. That is important. And we are not preventing it. That, unfortunately, is a simple thing. What is the differential diagnosis? Well, you have all these things here. Alcohol abuse, uremia, hypothyroidism, vitamin B12 deficiency, peripheral arterial disease, cancer, inflammatory and infectious diseases, and neurotoxic drugs. Frankly, if you take a decent history, you would rule all this out. Now, I don't know how you'd rule out. I am not one, well, I don't own a pharma, in a laboratory, there's a franchise, so I can't ask everybody to do B1, B2, B6, B12, this, that, because that would mean money to me. So should we give some sort of a B-plex tablets? I have no idea. So what is the way forward? Now, the other thing, I've shown this figure not because of anything else, but we tend to forget, when we talk of nerves, we tend to forget that even the vessels are important. So you have to look at the overall picture when you're talking of peripheral neuropathy. This, I'm not going to go into details about it. What are the risk factors? Well, age. The older you grow and you have diabetes, this thing. The greater the duration of diabetes, the greater the chances of getting neuropathy. Hyperglycemia, hypertension, cholesterol, triglycerides, and smoking, all are risk factors. Now look at this. This is slightly old data, but look at this for glucose control, HbA1c. 12.4% more than 10, 20.2% more than 9, 37% more than 8, while the recommendation is about 7 or 6.5. So obviously, almost 60 to 70% of the people are not under control, right? But this is data, top 10 universities in the United States. So if this is the problem in the top 10 university hospitals in the United States, you can imagine what the situation in most of the other parts of the world and in India must be. So that is the problem, that we have to think of controlling them. Diabetes is much more than glucose. I've always shown this slide because frankly, if I were ever an examiner and somebody came and told me that, no, you must give me a diploma in diabetes because I can control glucose levels, I would flunk him for 5 years at least. Because diabetes is not glucose. Diabetes is much more than glucose. That's the whole point. HbA1c you must control, BP you must control, lipids you must control. And look at this. You're talking of ABC control. But just see the end part. If you are looking at a person who's controlled ABC control, you have less than 15% even today who are at ABC control. So that is how bad things are. Then of course we can keep arguing whether it should be 130/80 or 140/90. I'm not going to go into that. But use an ACE or an ARB and get things as low as possible. Definitely don't try to get below 120 because that causes other problems. A statin a day, that's my opinion, keeps the doctor away. And what do? You suspect DPN-based history and clinical examination, you confirm neuropathy, exclude non-diabetic causes, explain the diagnosis. Today, people, we have forgotten how to talk to our patients. I have seen all so-called, I'm not a great expert in diabetes, and I don't consider myself a big shot diabetologist. But I've seen so-called big shot diabetologists. The patient is sitting in front of them trying to talk, and they are on their phone, texting away or doing what, I have no idea. Please talk to your patients. Talk to your patients. Why? I'll tell you one thing. All of you treat diabetes, right? Tell me one thing. Today we say that India has 74 million people with diabetes. That's a bad sign. Of course it's a bad sign. But do you know that 60% of our 74 million people do not know that they have diabetes? Why? I want to know why. Can't you ask your people, do you have a brother, do you have a sister, have you got your parents checked, or if they're elderly, have you got your children checked for diabetes? No, why? Oh, come on, I have to see 25 patients, I have to see 30 patients. I sit in my hospital lounge, and things have changed over the last 30, 40 years. At one time, we used to sit and discuss serious patients and what to do with them. Today, it's how many patients are you seeing? How many surgeries have you done? How much are you working? Even the hospitals want to know that. That's where the whole problem is, unfortunately, because it's become completely commercialized. Diagnostic mechanisms, well, we have got a lot of machines. And I'm sure I've not shown all the most sophisticated ones. We have the machines, but do we really need them? No. We don't need any of the machines. That's the point. This is according to American Academy of Neurology. Symptoms alone have poor diagnostic accuracy. I agree. Signs are better predictors. Multiple signs are more better. But relatively simple examinations are as accurate as complex scoring systems. And all you need is this. All you need is this, frankly. Three plantar areas, 90% sensibility and 80% specificity. Just three, point at them. How many of us ask our patients, okay, remove your shoes or socks or whatever it is, and let me check? Tell me. How many of us? Thank you. That's the point. All you need is a hammer, a tuning fork, a brush. I don't even know what a Mikado is. A simple bedside test can do loss of ability to sense vibration and movement of toes or feet. You know, you just ask them to move their toes up and down. Do they know it's up or down? If they cannot make out whether it's moving or it's up or down, that is neuropathy. Loss of ability to sense pain, light touch, temperature, loss or reduction of the Achilles tendon reflex. That's all you need to diagnose it. The question is that we don't do it because, you know, come on. I have no idea why we don't do it. And it gets very irritating when you ask a person after 20 years who comes with an ulcer or wants this thing, have you had your foot checked? Yeah, doc. What was checked? No, they ask me, how are my legs? Am I walking or not? Hello, you can walk even with everything else, but the question is, did you check? That's the whole point. Early diagnosis for risk of developing diabetic neuropathy. I'm not going to go into that, but small fibers. Look at this. This is in the control. When you have metabolic syndrome, the nerves become thinner, and in diabetes, they become completely thin. Same thing here. but people will say that, oh, that means I have to take a biopsy. Nobody takes a biopsy, so you can do something else which is known as corneal confocal microscopy. Now this is, see on the top you will see normal, on the right hand side you can see how thin the nerves have become, and that is one photograph takes in. But frankly, I don't see the need for all that. I don't see the need for all that, but all you do is use a Sims-Weinstein monofilament. That's all that you need. Please, people, use it, give it to your old elderly patients. I am planning to ask Bansi whether Diabetes India can come up with maybe and distribute to any doctor who wants at least 50 Sims-Weinstein monofilaments to give to their patients so that somebody can check at home and find out what's happening. Okay? This is another thing, the higher the triglycerides, the greater the chance of neuropathy. The higher the HbA1c, the greater the chance. But look at this. This is a very interesting thing which I didn't know, frankly. The higher the triglycerides, the greater the chance of neuropathy. But if a person's height is more, the chances of his getting peripheral neuropathy are much more. So for the same triglyceride level, the taller the person, and I'm sorry, I see him hunching down a little bit. You're not allowed to do that. If you're tall and you have greater chances. This is the latest thing that is happening today. As you know, I am an old man, and those who are old may remember a singer called Bob Dylan, who once sang a famous song, "The Times They Are A-Changing," and today everything is inflammation. Chronic inflammation causes diabetes and causes most of the complications, but I'm not going to go into that. The treatments are all there: lipid control, glycemic control, aldose reductase doesn't work, ACE inhibitor, alpha lipoic acid, does it or does it not work? I don't know, and it all causes neuropathy. The pain of neuropathy is of a burning and unremitting character. I experience sharp, this is what patients have complained, I experience sharp electric shocks. When I wake up, it feels like I'm stepping on broken glass. What do? You improve the physical functioning, you're going to reduce the psychological distress, and prevention if applicable. And this is a study, look at this. Even from Denmark, in a survey of patients with spinal cord injuries, were they treated properly with effective agents? Only 7% were. In a Boston pain clinic, were the patients given adequate doses of neuropathic medicines? Only 12% were given. So that's where the problem comes in. What does the ADA say? And I think it makes a lot of sense. Consider pregabalin or duloxetine. That's it. This is for pain relief. Okay? Pregabalin, most extensively studied drug, with majority of the studies being positive. Various US FDA non-approved agents including gabapentin. TCA should be used in caution. Given the high risk, don't use opioids. This is, of course, a flow chart which everybody has. Side effects of the drugs and the daily doses. Now, if you look at this is exactly, even the Academy of Neurology says so, pregabalin is the one to be used first. Now, they say 300 to 600 milligrams per day. I don't know, I find maybe it's the Indian patients. I find 75 to 150 is more than enough for people to get tremendous relief. Does pregabalin work? You can see it works. It goes up, 62% people respond to pregabalin. The sleep becomes much better with pregabalin. Duloxetine also is an excellent drug. Everything else, if these don't work, you can try it. Foot problems, frailty and falls or diabetic autonomic neuropathies are important aspects. Now, this is something again that most books will not mention, but from this thing, let me tell you. When you have an elderly patient with diabetic who has complained of a little bit of numbness or tingling, what basic advice do you give them? Or do you give their family? Anybody? Okay, one. But the first advice is, is when you go to the toilet, do not lock the door from inside. How many of us have patients who come and tell you, the families come and tell you that almost break them down because somebody fell inside and could not get up? Just don't lock the door, for God's sake. The other thing, very simple, and I always tell them when they first think that I'm being stupid, then they realize what? That when you are washing your face, please stand like this. Spread your legs and stand. And they want to know why. Because the point is, when your nerves are affected, it is your eyes that tell you where you are standing and how you are standing. But when you are throwing water on your face, eyes closed, and you start shaking. So to avoid falling down, the thing you do is just spread your legs. Believe me, people, I've been doing it for 30, 35 years, and I have had only 2 people who have ever fallen down. Okay? Do it. These are simple things. They cost nothing, for God's sakes. But all you need to know is to have some time to talk to your patients and tell them why you're doing it. It's not all the latest medicines that is always important. If you can prevent problems, why not do it? Emerging therapies, lots of them, most of them have to do with inflammation. I think statins work very well, but other inflammatory agents are being tried. And I think I'm going to, what I have tried to do really is to tell you basic management of what it is and how we can prevent problems. I've not gone into the latest thing. I don't want to go into this, although I've got 25 slides which I could add into this, but that is right now not important, because even what we know we are not doing, and I think we need to do that first before we start talking of all the latest things. So is this the way forward? Well, like they say, these 2 doctors are talking, you think God would know, but he says even he's not sure either. So maybe. So as a recap, and that was me when I had a lot more hair, we do not have to be nervous about diabetic nerve problems. We just need to have the nerve to treat diabetic nerve problems early and efficiently. That's the whole point. Okay? I hope to see all of you all at the IDF Congress, which is being held in India. It's not the main IDF Congress. It's the one on complications, which will be held on October 25, 26, 27 in Hyderabad. And then, of course, Bansi would kill me if I spoke only of that and didn't tell about the Diabetes India Congress in Jaipur next year. Thank you.
Thank you very much, sir, for your wonderful and inspiring talk. I think we are running short of time, so whatever questions you have could be asked later. Thank you so much. The wonderful audience, I think we were all spellbound in listening to him. Thank you so much.
Dr. Rucha Mehta to felicitate our chairperson.
Today, there are 73 million people living with diabetes in India. That's greater than the population of France. Over 1 in 2 people living with diabetes in India are undiagnosed, placing them at an increased risk of life-threatening complications. With India at the forefront of diabetes epidemic, Hyderabad has been chosen to host the first IDF Diabetes Complication Congress, a new series of IDF live education events focused on addressing the specific burden of diabetes complication. The Congress will mark IDF return to India after more than 40 years. IDF 2018 will feature over 100 international experts and a dynamic program spread over 9 streams that will showcase the latest research, treatments and tools to limit and manage diabetes complications. IDF 2018 is accredited with 15 European CME credits and Indian CME. Don't miss a chance to enhance your skills and grow your network. We'll look forward to seeing you in Hyderabad for the first IDF Diabetes Complication Congress. Today, there are 73 million people living with diabetes in India. That's greater than the population of France. Over 1 in 2 people living with diabetes in India are undiagnosed, placing them at an increased risk of life-threatening complications. With India at the forefront of diabetes epidemic, Hyderabad has been chosen to host the first IDF Diabetes Complication Congress, a new series of IDF live education events focused on addressing the specific burden of diabetes complication. The Congress will mark IDF return to India after more than 40 years. IDF 2018 will feature over 100 international experts and a dynamic program spread over 9 streams that will showcase the latest research, treatments and tools to limit and manage diabetes complications. IDF 2018 is accredited with 15 European CME credits and Indian CME. Don't miss a chance to enhance your skills and grow your network. We'll look forward to seeing you in Hyderabad for the first IDF Diabetes Complication Congress. Today, there are 73 million people living with diabetes in India. That's greater than the population of France. Over 1 in 2 people living with diabetes in India are undiagnosed, placing them at an increased risk of life-threatening complications. With India at the forefront of diabetes epidemic, Hyderabad has been chosen to host the first IDF Diabetes Complication Congress, a new series of IDF Live education events focused on addressing the specific burden of diabetes complication. The Congress will mark IDF return to India after more than 40 years. IDF 2018 will feature over 100 international experts and a dynamic program spread over 9 streams that will showcase the latest research, treatments and tools to limit and manage diabetes complications. IDF 2018 is accredited with 15 European CME credits and Indian CME. Don't miss a chance to enhance your skills and grow your network. We'll look forward to seeing you in Hyderabad for the first IDF Diabetes Complication Congress. Today, there are 73 million people living with diabetes in India. That's greater than the population of France. Over 1 in 2 people living with diabetes in India are undiagnosed, placing them at an increased risk of life-threatening complications. With India at the forefront of diabetes epidemic, Hyderabad has been chosen to host the first IDF Diabetes Complication Congress, a new series of IDF Live education events focused on addressing the specific burden of diabetes complication. The Congress will mark IDF return to India after more than 40 years. IDF 2018 will feature over 100 international.
Hello. A very, very warm good evening to one and all. I welcome you all to the 4th annual DiaCon 2018. I take this opportunity to invite our very esteemed guest onto the podium. I invite Dr. S.M. Sadikot, sir. Dr. Vikram Shah, sir. Dr. Asha ma'am. Dr. Ali Shian. Dr. Hardik Chandarana. And our very own Dr. Banshi Sabu. Let's have a round of applause for all of us. Okay, while everybody is getting seated, let's talk a little about diabetes. Oh, how could I forget him? Dr. Nitin Suman Shah, sir. Please join us on the dais, sir. Nitin Shah. Okay, we have Dr. Sadikot sir on this stage already, Dr. Vikram Shah sir, Asha ma'am, Nitin sir, Hardik Chandarana, Ali Shriyan sir. Okay, let's just give him a minute. All right. So continuing with the program till everybody gets settled on the podium, talking a little of diabetes. All of us here, medics, non-medics, paramedics, all the healthcare professionals. Dr. Bhupendra Shah is here. Oh, right. Oh, Dr. Bhupendra Shah sir. Dr. Anil Kulshetra, sir. Anybody else? So man of the match, Dr. Hardik Chandra, left to take the, all right. So restarting again, all of us here are aware of the fact that diabetes is a very highly prevalent disease. The incidence is increasing by every minute. In spite and despite of so many numerous conferences, CMEs and meetings, there are still 2/3 of diabetic population who are out of their A1C target range. We at DiaCare feel that continuous diabetes education may not have still shown any significant statistically relevant data and made any relevant difference, but it does make a small difference to that one patient who is seen and managed by a very well-trained physician or diabetologist. Keeping that in mind, the idea and motto of continuous diabetes education, we each year strive to have a better scientific material at DiaCon. The DiaCon kit this year has a feedback form wherein you can tell us what improvements you want us to make and what newer topics you want us to integrate in our next DiaCon. With this, without wasting any more time, I would like to start with a small Ganesh Vandana.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
So let us all bow to the great Lord Ganesha so that he removes all the hurdles in the management of diabetes. I would now ask and request Dr. Banshi Sabu sir to give his welcome address and inaugurate the ceremony.
Good evening, everybody. I am Dr. Bansi Sabu, Chairman DiaCare. Warmly welcome one and all of you to this fourth successful edition of our DiaCon. I take this humble opportunity to welcome our chief guest tonight, Dr. S.M. Sadikot, who is immediate past president of International Diabetic Federation. He is my guide. He is big support to me. I request my wife, Mrs. Anuradha Sabu, and Smita Ben to welcome him with a bouquet of flowers. Please. Thank you, sir. Thank you for sparing your very valuable time. I now take this chance to welcome our guest of honor, Dr. Ali Shian, who is International Diabetic Federation Southeast Asia Chair, who had come all the way from Maldives. We are very happy to have you here. I request Dr. Jyoti Dev, very close friend of mine, to welcome him with a bouquet of flower. I request Dr. Jyoti to give a bouquet of flower, please, to Dr. Ali Shian. Thank you. Our very important initiative this year has been expanding our care of diabetes throughout city of Ahmedabad by different ways and venture. And one of the venture of DiaCon is, or DiaCare, is with the Shelby Group of Hospital. I would request Dr. Shruti to welcome Dr. Vikram Shah with the bouquet of flower. I am sure many of you must be knowing Dr. Vikram Shah, who is an eminent orthopedic knee replacement surgeon of the country, who must have done highest number of knee replacement in our country, who is a chairman of Shelby Group of Hospitals with more than 13 hospitals across the city, and he is an entrepreneur. Sir, thank you very much. I'm so happy to welcome my teacher, my guide, Dr. Asha Shah, who is a mentor for DiaCon, who is a mentor for me. And I request my close friend, Dr. Rucha Mehta, and colleague, to please welcome her. Thank you, Rucha, and thanks, madam. I would like to welcome now President IMA, Indian Medical Association, Dr. Bhupendra Shah. I request Dr. Dharmendra Panchal, please welcome sir with a bouquet of flower. Bhupendra bhai, thank you very much for coming here and gracing the DiaCon. We have Dr. Anil Kulchestra among with us. He is the President of Association Physician of Gujarat. He is a very, very excellent human being. I would ask Dr. Urvi Parikh to please welcome him with the bouquet of flowers. So I request Dr. Urvi to welcome Dr. Anil. Thank you, Anil bhai. Now I request Dr. Pratap Jethwani to welcome Dr. Nitin bhai. Dr. Nitin Shah is fatherly figure for me. Thank you, Dr. Nitin bhai, who is the president of DiaCon. So I request Dr. Pratap Jethwani, who is the secretary of RSSDI Gujarat, and who is also is organizing secretary for RSSDI, which is coming to our city of Ahmedabad. This year, we have invited many international faculty. The idea of inviting few international faculty to this DiaCon, because we know that to keep diabetes under good control, the biggest issue is hypoglycemia. And we have with us Dr. Simon Heller, who is expert in hypoglycemia, who is the world authority on hypoglycemia, and he is running an international hypoglycemia group. So I request Dr. Bhavesh Patel to welcome Dr. Simon Heller with a bouquet of flowers. The second biggest problem after the control of diabetes, actually we all want to prevent diabetes. That's what we want. And we have the authority in this world on prevention of diabetes, who is the president of World Congress of Prevention of Diabetes, to Dr. Jacko. So I request Dr. Myra to welcome Dr. Jacko on the stage with a bouquet of flowers. And we are really thanking you, sir, from all the way you had come from Finland. Thanks. Todd had come. Todd had come. Todd had come. Oh, he's here. As we have more of type 2 diabetes, and that's the reason we have some type 1 diabetic patients also, but the importance of control of type 1 diabetes by most of the physicians and primary care physician is almost negligible. We are not taking care of them so efficiently as we are doing for type 2 diabetic patients. And for this, because the pediatric diabetes, type 1 diabetes, very, very important, we have already started under our DiaCare, in chain of DiaCare, one dedicated clinic only for type 1 diabetic patients. And we have with us Dr. Todd. He is not here just now. Okay, he is coming on the way. He's already, oh yes, he is there, Todd, please. So I request my close friend Dr. Jitendra Nagar to welcome with a bouquet of flowers to Dr. Todd, who had come all the way from University of Colorado, from US, who is an expert on a pediatric diabetes, a type 1 diabetes expert. I also would like to acknowledge few more. So I request Dr. Viral, who is working with me, to welcome the Chief Operating Officer of Selby Group of Hospital, Dr. Nishita Shah. I will request Dr. Pratiksha Chawda to welcome our most trusted mentor and guide, Dr. O.P. Gupta, Bhishma Pitama of Diabetology in India, who is the founder president of RSSDI, a living legend for diabetes, Dr. O.P. Gupta, who made diabetes a successful branch of practice. A very important person for us, Dr. Muruganathan, who is the governor of ACP India branch, who had come, who had delivered a oration just before some time. So I request Dr. Deepak to welcome Dr. Muruganathan with bouquet of flower. Dr. Deepak. We have here very many national faculties who had come, who have taken the pain to come from all over the country. Just to name few, we have Dr. Arvind Gupta, we have Dr. Rakesh Sahai, we have Dr. Sujoy Ghosh, and many more from all across the country. So I just welcome all of them, and I am giving them thanks also for coming from different parts of the country. Dr. Meenal is there, so many more, and there are many more who will be coming to next 2 days also. So I welcome them, all of them, at DiaCon. I also want to acknowledge the presence of some of very few important persons who had come to grace the occasion of inauguration of this conference, particularly my sisters, my brother, and my bhabi, and my kids and family members. I also want to acknowledge the presence of Subjyoti Ghosh, who is here. Yes, who is my first PhD student, and I am very proud to have him here, who had come all the way from Northeast, and he is doing a PhD thesis under me. I also would like to mention a special welcome for very young type 1 diabetes mentor, Jess Sethi. If she is here, I would like to acknowledge her, Jess Sethi. If she is here, who is doing her share of work to spread the awareness about type 1 diabetes through blogs and YouTube videos. So I welcome Jess. She confirmed me that she had come here. I extend a warm welcome to all the delegates from different parts of the country for coming here to the feast and associate with us. I also would like to welcome all the industry partners, all the persons who had come from the different pharma industry and who are here. So I welcome them all to be here at inauguration to grace this occasion. Welcome to all guests, pharma industry representative, press, and one and all at the 4th edition of DiaCon. Once again, thank you, and I welcome you all.
So now I can say we have officially welcomed one and everybody to the 4th edition of DiaCon. Welcome once again. Can I now request Dr. Asha N. Shah to please say a few words of wisdom.
A very good evening to all. Dignitaries on the dais, starting in no particular order, Dr. Hardik, Dr. Bhupendra Bhai, Dr. Nitin Bhai, Dr. Vikram, Dr. Sadikot Sir, Dr. Ali Shan, Dr. Anil, Dr. Bansi, and distinguished guests and friends. It gives me great pleasure to see you all here in Ahmedabad on this pleasant evening. Dr. Bansi and his team have worked very hard to prepare this outstanding conference. The quality of the program is world class and the spectrum of topic is very current and useful. To organize a national level conference in itself is a mammoth task, but to do it, Dr. Bansi and his team now, they are veterans in organizing these perfect conferences. May God Almighty bless them for this event and all the future endeavors. We are lucky to get the opportunity to hear and learn from renowned speakers. And your audience, your strong support and active participation will make this a memorable event. I thank Dr. Bansi for giving me the opportunity to talk to you all and wishing you all the best. Thank you very much.
Thank you so much, ma'am. I would like now to request Dr. Vikram Shah, sir, to please say a few words.
Dear friends, I congratulate Dr. Bansi Sabu for doing commendable job, doing 4th meeting in row. For you, I am an outsider because I don't understand diabetes much, so I can't speak much about diabetes. Having said this, we do require diabetologists to treat our patients because we operate only after diabetes comes in control. So actually we are on receiving end from physicians and diabetologists. I have a couple of observations on diabetes. A mankind or Homo sapiens, as scientifically we call it, got first surge of diabetes probably because of two inventions: agriculture and cooking of the food. Agriculture was the first industry, and we started growing grains and started cooking it, and then that was an easy sugar. But in my opinion, two very large surges came in last 100-200 years. First, industrialization in general, which reduced physical efforts by mankind. And second, industrialization of food, readily available food, which increased obesity to the highest level, which we are watching since last 50 to 80 years only. The other day I was watching National Geographic channel, and I tried to understand that none of the wild buffalo is fat, all are same. Or none of the wild beast is fat, all are same. You cannot recognize any fat animal. But we do have fat human beings. So we are doing something wrong and they are doing something right. So we should learn from them that what they are doing right. We are cooking everything. And we are eating lot of ready food. Probably our enzymes are not matching the rapid speed of digestion of those food. This is what I have understood. Thank you very much.
Thank you, sir. Maybe we all will agree with what you said. We have with us Dr. Ali Shian, sir, from the IDF Southeast Asia region. May I ask you to please, sir, say a few words.
Guest of honor, immediate past president, Dr. Shaukat Sadikot, honored guests, organizers of DiaCon 2018, delegates, ladies and gentlemen, good evening. First of all, let me express my gratitude for speakers before me who is for the welcome Dr. Bansi Sabu had given us and the words of wisdom that we heard just now. Especially, I am very grateful to be invited as a guest of honor here today. As Regional Chair Southeast Asia for the IDF, I eagerly look forward to attending such events and making acquaintances with fellow professionals in the field. It is indeed a privilege to be seated here among such esteemed personalities in the field of diabetes. Thank you so much, Dr. Bansi Sabu and the organizing committee, for giving me the opportunity and the honor. We are all gathered here today to gain knowledge and wisdom from such conferences, and we all return back like fish return into ponds after 2 days to look after our diabetic, sick and poor patients. Some of us will teach the young and enthusiastic, and some will reflect what has been learned and hopefully challenge the conventional wisdom and practices of medicine and ask ourselves, can we improve our care and relieve the pain of our patients? We all indulge in research and knowledge and strive to gain more because we have hope. We have hope that there are better ways of understanding and managing diabetes and restoring the health of people under our care. But how do a single individual like ourselves have an impact on such a mammoth task such as dealing with diabetes in a community like us? A wise man once said, the best way to contribute to the society is to make yourself a valuable tool, a useful tool. It is not just about making loud noises and criticizing, not just pointing fingers or even daydreaming about an environment where everything is set on a plate, where facilities, funds and resources come to us. But it is about, and it is especially not about being proud of how knowledgeable we are in the field of diabetes, but it is about making ourselves useful tools, like many of us here before us have proven to be. Today we are here to obtain knowledge that will hopefully make us all take a deep breath and raise our eyebrows, and after 2 days hopefully leave with a smile. Smile because knowledge practiced will help bring health and better life to our patients and our communities, our countries. I wish you all a wonderful learning experience and thank you for your time. And thanks the organizers once again for having me here. Thank you.
Thank you very much, Dr. Alishian. Now we move on to a very, very exciting part of the evening. We have an award distribution. Awards are always good, but we need to recognize them, encourage them, and motivate them to do much better every time and strive and work hard to do the best that we can. And to do the honors and to announce the awards, can I please have Dr. Banshi Sabu sir again? And I think we need some little activity of applause here.
Yes. This year we thought of doing a Young Investigator Award for few of the young investigators across the country. We were having many nominations for these. Our credential committee was with Dr. Asha Shah, who is here, Dr. A.K. Das and Dr. Shashank Joshi, who were in the credential committee. And we have 5 winners for that. The award which we had kept the name on my mother's name, Dr. Mrs. Geeta Devi Damodalal Sabu, New Investigator Award. To give the award, I will request our chief guest and guest of honor, but I also would like to invite to give the award my elder brother, Surendra Sabu, and my elder sister, Pushpa Devi Somani, if she is here. So I now request the first award goes to Dr. Madhurima Basu. The Madhurima Basu, she must be here. Pushpa ji, kone kya? Saroji ji? Anybody? Papu, you go there. So I will request Dr. Sokas Sadikot to give the first award to Dr. Madhurima Basu. She will be presenting her paper. This is a cash award of 51,000 in the name of my mother. she'll be given the travel and stay and registration also. Sarojiji, you go. Sarojiji, you go. To give the second award, I request Dr. Vikram Shah to give this award to Dr. Sudhanshu Gupta. I will again request Surinder and Sarojiji to stay there. To give the second award, I will request Dr. Vikram Shah to give to Dr. Sudhanshu Gupta. We have the third awardee is Dr. Om Lakhani, who is not here. We have Dr. Pranita Ashok, who is the winner for the award. So I request Dr. Ali Shayan to give this honor to Dr. Pranita. Pappu, you be there. And now I request Dr. Nitin Shah to give the award to Dr. Akshada Ishwar. A big round of applause for Dr. Akshada. She is daughter of Dr. T.K.M. Ishwar, very close friend of mine. Dr. Akshada, congratulations. Thank you.
Thank you so much, Banshi sir. And I would again like to congratulate all the winners of Geeta Devi Damodarlal Sabu and New Investigators Award. Congratulations to all of you. Let's just all applaud them. A fire makes everything pious. That is how our Vedas say. I would like to invite everybody on the podium to please come forward for a small lamp lighting ceremony. Oh. Okay. Dr. Jaco, Dr. Simon and Dr. Todd, please join us on the stage. Do we play something? कोई गाना होगा? Thank you. Thanks to all the dignitaries. You want to say something? Book. Oh, yes. I would now like to request Dr. Banshi Sabu sir, all the dignitaries on the stage again. We have a small book release ceremony. Can we have the books on the stage, please? Yes, I will. You need to open it first. This book Clinical Management of Diabetes, has its special role in the contribution to the fraternity of diabetes and continuous education in teaching a lot of us on how to manage and take care of all our patients with diabetes. So do you want to say a few words about the book? Banshi sir. Yes. Again at DiaCon. You're the correct person to talk about it.
And he wanted to have it for the primary care physician. That's the reason we have re-edited this book completely, because all of you know that in last 15 years, diabetes management is completely changed. So we re-edited this book, and second edition of this clinical management of diabetes had come. And it's really great pleasure that now we have the 10,000 copies of this book is already published, and it is been distributed across the country to many of the physicians and primary care physicians of the country, which will be distributed in next 1.5 months before even our RSSDI. This year also we could get our Sadikot textbook of diabetes, which had officially released in Diabetes India, and which is taken up by more than 6,000 copies taken up by our industry partner Torrent Pharmaceutical. I am personally thanking them, and it is getting distributed also across the country to many of the physicians and postgraduate students for that. Thank you very much.
Thank you so much, sir. Now, the very person with such a broad ideology of how to take care of patients with diabetes, we have amongst us Dr. S.M. Sadikot, sir. Please, sir, give us the chance to listen to you.
Well, thank you. And I would like to really start by thanking Bansi. And I would just like to say a few words about him. I know that if I told him I would say these things, he would say, no, don't do it. But I have to tell you that one of the best things that has happened in my life is getting to know Bansi, who's always been like a younger brother to me, or maybe once he called me like his father. So I am that old, I think, or I don't know what. But I am really, really thrilled that he's come into my life. I think most of you who know me know that health-wise I've gone through a lot of nonsense in the last year. And I must say that besides a lot of other friends, one solid rock that was always around to help, although he stays in Ahmedabad and I'm a Mumbaikar, was Bansi. And Bansi, thank you very much. And I know that in the recent couple of months he's gone through a lot of personal grief also, because he lost his mother. And I think considering the awards and considering all this, I don't think would really have been possible without her support for Bansi. And I would like really all of us to stand up for a minute in her memory, and her soul rest in peace. Thank you. Now, I'm going to just spend 2 minutes or 3 minutes to say a few things. Don't want to go into the past, but my sugars are normal, and I just want to say one figure. 1240. Anybody knows why I said 1240? Anybody, please? 1240. Well, the reason is, I think it's important because as of today, we are 1240 days away from 100 years of the first insulin injection given, which failed. But 12 days later, that is 1252 days from today, an injection was given to Leonard Thompson, and that worked. And I think what we need to do, not only Diabetes India, but DiaCare and RSSDI and everybody, is I think come together and do something so that at the end of 1252 days, we are able to tell the world that yes, we all joined together, did some project, did some initiatives to make the lives of our people with diabetes better. And I would really, really hope that all of you all, in your own way, will join us. We would definitely be in touch with you. And we hope that we can do something. Because like I always maintain, all our work has to have one focus. And like one of our Mahatma Gandhi once said, and this is something that my father, who used to be a foot soldier when they were fighting for independence, always used to tell me, what Mahatma Gandhi used to tell them, is that when you start thinking of doing something, and it seems very hard and almost impossible, think of the most poor and the most vulnerable person you know. And if what you are going to do is going to bring a small smile to the face of that person, then that must be done irrespective of the hard work and irrespective of the cost. So I say, let us all join together, people, and let us look at our people with diabetes, not the multimillionaires who can fly to Jocelyn Clinic and get their test done. But we've got a lot of common people, poor people in the villages, in the people transiting and coming to cities to work, leaving the families behind, who have diabetes. And I think we need to do something to bring a small smile to their face. Thank you very much.
Thank you, Dr. Sadikot. We now come to the end of the ceremony. And why not have a word of thanks from the person who is behind the scenes of DiaCon each year. I would like to invite Dr. Hardik Chandarana to give the vote of thanks for DiaCon.
Good evening, everyone. Thank you, Dhruvi. Before I start my vote of thanks, I would first like to show the hard work which has been put together by my team. So there is a small video of 1 minute. I would just request the audiovisuals team to play this video. Behind the scene. Yes. So this year we just had an idea that, there are a lot of people who are working behind the scene, but we don't recognize them most of the time. So we have created the entire video and we tried to compile it in just 1 minute because we don't want to take much time of yours. So will it take time? Then we can show it in the end. Final meeting we had.
So, thanks to our team. And before I start vote of thanks, there is one more thing. We have President of Association of Physicians of Ahmedabad, Dr. Mustafa Rangwala. So I would request Abhilasha to kindly welcome him with the flower of bouquet. He could join us late because of some other commitments. Thank you, sir. So, I feel honored to pronounce vote of thanks on behalf of the entire organizing committee of DiaCon 2018. First and foremost, I would like to thank Almighty God for blessing us all and bringing all of us under one roof today on this auspicious day. I humbly thank our chief guest, Dr. Sadikot, immediate past president of IDF, for being here in spite of his busy schedule for organizing IDF meeting next month in Hyderabad. I thank Dr. Ali Shian, who is chair of IDF Southeast Asia, for making it possible to grace the inaugural ceremony of DiaCon 2018. I also thank Dr. Vikram Shah, who is director of Selby Hospitals, for making it possible. He had to leave because of some emergency. I would also like to thank our father figure, Dr. Nitin Suman Shah, who is patron of DiaCon 2018, for all his support and guidance throughout organizing this conference. A word thank will be too small for respected Dr. Shashank Joshi, unfortunately who could not be here, for his support and guidance for making the scientific program of DiaCon. And thanks to respected Professor Asayan Shah, who is also our mentor for this conference and guided us in organizing this meeting. I would also like to thank Dr. Bhupendra Shah, who is President of Indian Medical Association Gujarat branch, Dr. Mustafa Rangwala, President of APA, Dr. Anil Kulshrestha, President of Association of Physicians of Gujarat, Dr. Abhay Dikshit, President of Gujarat State Family Physician Forum, for their gracious support in organizing this conference and bringing lot of physicians for this meeting. I would like to give my thanks to Professor O.P. Gupta for his valuable presence in this inaugural ceremony. A special thanks to our national coordinators, Dr. Sudhir Bhandari, Dr. Jyotidev Keswadev, Dr. Sunil Gupta, Dr. Manoj Chawla, Dr. Jayant Panda, and Dr. Mithun Bhartiya. I also thank our regional coordinators, particularly Dr. Pratap Jethwani, Dr. Bhavesh Patel, Dr. Chintan Vyas, for helping us in this mega event. Thanks to the entire advisory committee of DiaCon, particularly Dr. Navneet Shah, Dr. Mustafa Rangwala, Dr. Abhi Chandani, Dr. Badlani, and Dr. Bhagirat Solanki. Sorry. Scientific program was designed under the guidance of scientific committee members, namely Dr. Urmandru, Dr. T.K.M. Ishwar, Dr. Sanjeev Phatak. So big thanks to all of them, and Dr. Rucha Mehta also. A conference is what its enlightened faculties make it. So I would like to express my sincere thanks to all the faculties, particularly the international faculties who has traveled from different part of the globe, namely Dr. Simon Heller, Dr. Jaco, and Dr. Guy, for traveling all the way to the beautiful city of Ahmedabad. And I would also like to thank few of the national faculties, particularly Dr. Murugnathan, Dr. Arvind Gupta, Dr. Siddharth Das, Dr. Rakesh Sahai, Dr. Samar Banerjee, and all of you. I don't know how to thank a person who is behind everything you see here. And he is none other than my boss, my guru, and my elder brother, Dr. Bansi Sabu sir. I would particularly like to thank him for this year for giving me free hand in organizing this meeting under his guidance and putting trust on me. Special thanks to you, sir. I am thankful to all our industry partners who had supported this meeting in a big way, particularly Aris, Sanofi, BI, AstraZeneca, Lilly, Novo Nordisk, Sun Pharma, USV, MSD, Intas, Novartis, Torrent, Abbott, Zydus, Aprica, Joster, and all others. At this juncture, I would also like to thank the organizing committee of DiaCon 2018, who has helped me a lot in organizing this conference, particularly Dr. Dharmendra Panchal, Dr. Dhruvi, Dr. Rutul and Dr. Vipul, who are not here unfortunately, Dr. Feni, Dr. Deepak, Dr. Mahira, Dr. Viral, Dr. Shruti, Dr. Krishna, and above all the pillar from organizing committee, and I would fail if I don't thank her. So heartfelt thank to Payal Sabu. She is not well, so she is not here, but she has handled this event single-handedly. So big round of applause for Payal. I thank the energetic team of DiaCare for their tirelessly efforts for making this conference successful, particularly from our account department, Kailasji, Amit, Abhilasha, Piyush, Ashok, Jaideep, Vishakha, Jigisha, Purvi, and all other staff members of DiaCare. I am sorry I am not naming each one of you, as you all are very important family members, but the list is getting bigger and bigger as our team is growing. Big thanks to management of Hyatt Regency for providing us wonderful venue. Thanks to our travel partner Jay Agrawal, Mr. Vivek from Vertical Circle Studio for designing the theme of the conference, Grover Audiovisuals for providing us wonderful audiovisuals, and Laluji and Sons for the providing fabrications. And each and every person who has helped us in organizing the meeting. At last but not the least, I would like to thank the most important individuals of any conference, that is our delegates. So I personally thank each one of you for being present here, and I am sure you will enjoy the scientific feast for next 2 days. And if you are traveling from outside the Ahmedabad, you will enjoy the city of Ahmedabad. Before I end, I would like to thank my parents, my wife Neelam, and my son Naksh for their constant support. If I have forgotten to giving thanks any person or any organization, then please forgive me, because it is absolutely unintentional. Once again, thank you all. Thank you from the bottom of my heart.
Wow, that was a lot of thanks, Dr. Hardik. We, on behalf of the whole DiaCare team, thank you for giving us this opportunity to have been a part of such a huge conference. Thank you, Dr. Hardik. Thank you, Dr. Banshi Sabu. Thank you, and from the bottom of all our hearts sitting here, all in the grey coats, thank you, sir. So, with this, let us all end with a national anthem. I request everyone to stand at
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
So we officially end the program and invite everyone for dinner. Please join us for dinner at Tinelo Lawn.